Sudha ma'am, start ma'am. Please unmute.
Good evening. Welcome you all to today's webinar on contact dermatitis. This webinar is being conducted on the idea of our president, Dr. Vani Patale. It is her unique idea to conduct webinars on allergic contact dermatitis, psychodermatosis, and vaginal dermatosis. We conducted two successful webinars on psychodermatology and vaginal dermatosis, well appreciated by all the people. So in continuation of that, we are conducting this third webinar on contact dermatitis. Without wasting our time, I'm inviting our president, Dr. Vani Patale, to give a presidential address and introduction. Madam. And Vani Patala Madam is our president from 2020, and she is a well-known academician, and she is very much interested in contact dermatitis and clinical dermatology mainly. Madam's interest is in clinical dermatology, and she is a co-founder of Hyderabad Women's Dermatologist also. She is the most inspiring dermatologist. She got Times of India Doctors Day Award in 2020. Madam, please.
Ma'am, unmute, ma'am, unmute.
Good thing. Good evening. Welcome to all to this contact dermatitis webinar. As Dr. Sudhani said, this was one of our on agenda programs, and we actually were going to do it with the CODFI, the Contact Dermatitis Forum of India. But they had their annual CODFICon, and we were Dr. Dinesh Mathur was good enough to give us a slot of 1 hour in that, and but still we wanted to do a little more and also involve people who have not been routinely involved, so that we get a different angle and maybe get more people interested in this field. I have been associated with patch testing and contact dermatitis for a long time. When I worked in England, I worked in the patch test division. There were 10 different consultants in this hospital, and Dr. Beck was doing patch tests, and I got hands-on experience from there. And after coming back, also attended a few workshops and started doing patch testing. It's a very interesting field, and it surprises me that more and more people don't get interested in contact dermatitis. Patch testing does require a little time, but it is still financially also viable. But you need to be interested so that you can use it to the best for our patients. So I'm hoping today we'll add some more people to this area, take up patch testing, take up what comes out of the testing, share that knowledge so that we can get more out of the testing and use it for the benefit of our patients. Now I'll go to the overview. So contact dermatitis, as the word suggests, is skin rash due to contact with something. Still not screen sharing. So we know skin is a large surface, nearly 1.5 to 2 square meters, and this is exposed to external environment, coming in contact with various substances. And the amazing nature of the skin is that it withstands so many by its compact surface, and still in view of this much exposure, the reaction to contactants is fairly less. But as time is going by, more and more developments, more and more chemicals in the air, loss of ozone layer, dry atmosphere, all these are adding to increase in contact dermatitis. And contact with various substances to either cause exogenous eczemas, either irritant dermatitis, which is a direct inflammatory response, or allergic dermatitis, which is due to immune-based reaction. There are non-eczematous contact-induced skin changes, which can be inflammatory or non-inflammatory. I think the term contact dermatosis might be more appropriate to include all these conditions arising from contact with external factors. So as I've already mentioned, there is eczematous, which includes irritant contact dermatitis or primary irritant dermatitis and allergic contact dermatitis. Here there will be a primary site. There could be a flare of existing dermatosis or non-resolving of any existing dermatosis. These should make you look for any contactant causing the problem. Coming to non-eczematous, there are various manifestations like just erythema, dyspigmentation, either hypopigmentation to leukoderma or hyperpigmentation, lichenoid reactions, urticarial, erythema multiforme like purpural, vesicular bullous, granulomatous, etc. Dr. Kavita will be dealing a little more in detail with non-eczematous conditions. So contact dermatitis is a whopping 20%. Allergic contact dermatitis is 20%, and irritant contact dermatitis is more common, almost 4 times as common as allergic. And as we know, this ACD is allergy-specific T lymphocyte mediated, and the re-exposure causes rapid development of the rashes. And it does not occur in unsensitized individuals, as opposed to irritant contact dermatitis, which is dose dependent, requires sometimes repeated exposure. No prior sensitization is required. Very often they can occur concomitantly. Coming to pathophysiology, there will be some repetition of things here, but the cutaneous response is dependent on the chemical itself, that is the allergen, the duration of contact, the nature of contact, and the host susceptibility. And as I said, ACD is type 4 CMI, cell-mediated immunity, whereas ICD is non-immunological, direct tissue reaction. Overlap can occur. Allergens in higher concentration which cause allergy can act as irritants. And for diagnosis of allergic contact dermatitis, patch testing is a gold standard. Again, this shows that initially innate immunity and non-specific immunity is the irritant dermatitis, whereas allergic specific immunity and adaptive immunity, both innate and adaptive work here. And both go through these phases, but as you see, the eventual necrosis, the effect on the cytokines and inflammatory infiltrate, all this will be similar in both conditions. Here, irritant dermatitis occurs because the damage to the skin because of the irritant is faster than the repair. And the most important the pathophysiological reasons are the barrier disruption, removal of surface lipids, epidermal cellular changes, and then cytokine release, which leads to further damage. So the initial allergen due to skin gets into the skin and then directly causes release of cytokines and then release of the inflammatory cells, and that causes the inflammation. The predisposing factors here are history of atopic dermatitis, occupational exposure or repeated exposure, low temperature and humidity, and the condition of the skin. Etiological agents for irritants are mostly excess watering, soaps, detergents, bleaches, lye, drain, pipe cleaners, toilet bowl cleansers, basically strong detergents, acids, alkalis, solvents and hydrocarbons, and fine particles like fiberglass, dust, and sometimes tear grass, capsaicin, and metal salts. Coming to ACD in epidemiology, 4 to 7% of dermatology consultations are thought due to allergic contact dermatitis, and there's more underdiagnosis than there must be more cases than that. And a whopping 20% of occupational disease, all occupational diseases, is due to contact dermatitis. So it's not a small problem; it's a huge problem, and I think we should address it more vigorously. Age variability is thought mostly due to the exposure, And gender, some variation, some hormone-dependent aggravations can occur, and nickel dermatitis in equal settings are supposed to be higher in women. It is less common in immunosuppressed, especially with impaired T cell function, and barrier cell disruption is the most important predisposing factor and comorbid condition. Some drugs like glucocorticoids, cyclosporine A, azathioprine, Sorelins, and UVB suppress patch tests, and the same way as they suppress the reaction. Predisposing factors are pre-existing dermatitis, be it constitutional like atopic, irritant, and the duration of it makes a difference. The longer that skin has been irritated, the more chances of developing ACD. Then trauma, strangely, acanthosis itself can be a predisposing factor. Occlusion is a major factor, especially for dissemination also. For example, stasis, perianal areas, gloves and shoes, etc. Coming to chemical factors, very interestingly, the antigen nature is quite important. They are mostly low molecular weight, less than 1000 Daltons, and positively charged electron deficient. The skin cells have negatively charged electron-rich proteins. So this is where the nature of the allergen is important. They are haptens which act directly like nickel. They can be prohaptens which are activated in the skin, for example, cinnamyl aldehydes and urochidols, and prehaptens, that is, they are activated externally, maybe due to oxidation or due to photons and things like that. So examples of this are fragrances and citrus fruits. The risk of sensitization depends on the penetration of the hapten, the concentration, duration of exposure, repetition, and any pre-existing allergies. Immune tolerance, interestingly, the genetic factor majorly is probably through the T regulatory cells. These cells are the ones which downregulate a reaction. So if these are functioning not properly, then the chances of developing ACD are higher. So very briefly, this is how it works. So the afferent limb consists of the allergen and the antigen-presenting dendritic cells that goes to the to the lymph node via the regional lymphatics. There, the sensitization occurs, and the naive cells becomes activated T cells. And when they go back to the skin and there is re-exposure, the again the dendritic cells present to this, and the inflammatory cascade is started. So the response to haptens itself depends upon the hapten's capacity to activate and mobilize the dendritic cells, and the generation of hapten epitopes for the T cell to recognize, and the hapten the complex ability to prime the effector cells with skin homing properties, and as I said, downregulation by T regulatory cells. So these are all factors which determine whether a person develops the allergic response to the hapten or not. So this is again pictorial. Here you can see that the releases of the cells and cytokines here from the blood vessels. And there is, interestingly, one important thing is that keratinocytes also add to the interleukin release, and the further the damage. That's why the pre-damage is important, because there the keratinocytes themselves start the inflammatory cascade. So how can the allergens cause CD? There are various ways. The direct contact, occasional contact from surfaces, transfer from another site of the body, which is called ectopic and very commonly seen. We know the popular example of nail varnish causing eyelid dermatosis. Another person, that is by proxy, either contact from another person, either from the consort or any, for example, adult to child. Then airborne, we all know that, and with associated UV exposure causing photoallergic contact dermatitis. Systemic contact dermatitis, that is contact dermatitis which is originally contactant, and then due to intake of it, the dermatitis develops. And then Dr. Nita will be talking about this. And of course, the EAD reaction or the autosensitization, which leads to generalized or disseminated contact dermatitis. And these are the common allergens: rubber chemicals, plastics, metals and their compounds, antimicrobials including formaldehyde, butyraldehyde, dyes, fragrances, and flora more than fauna. Flora is the most commonly causing worldwide is the Compositae family, including Parthenium. So how do we suspect? When you suspect, you ask for history of the primary site, the duration, if there are fluctuations, what is causing the fluctuations, occupation, hobbies, personal objects like clothing, jewelry, footwear, cosmetic and personal care products, applications and treatment. This will be the approach to any patient to diagnose or suspect atopic dermatitis and home in on what could be causing it. So what is patch testing, as I already mentioned, is a gold standard. What it does is actually gives us a definitive diagnosis. Of course, there are false positives, false negatives, but you have to take it in conjunction with the clinical picture. And then this epidemiology, the information we get from patch testing gives us treatment guidelines. So we cannot do patch tests in many people. So if we have a lot of information with the database, then for each area or we can suspect certain allergens and take precautions to treat our patients, to take treatment precautions to prevent as well as to treat. And as I said, occupational is 20%. So occupational rehabilitation might be required. This requires confirmation of what exactly is causing the allergy. So that's where the patch test plays a major role. And also to drive the pharma to develop products which are less allergenic. For example, my greatest thing is fragrance-free cleansers. You don't get easily. So whatever I was prescribing to the patients, they went out of production by the pharma companies. And now there is not a single soap which is fragrance-free, which I know of. So all the synthets will contain some fragrance because they say they have to use it to mask the smell. So if we have enough data to show that it is important for us to have some of these products and it is advantageous for them to come up with it, then we can do some influencing there. And for example, even parabens, preservatives and some products antimicrobials which we can avoid using. So many ways this will help, patch testing will help. So it should be done on a larger scale and more information gathered, and these decisions should be addressed to help us with all these aspects. Again, insurance, there also it comes, we have to have a specific diagnosis. And testing, patch test series updating. So for the last any number of years, we've had the same 20 ingredients in our Indian standard series. So we need to, if you get more and more information by testing other things apart from what's in the standard series, and also getting data on what is being newly included in the products, we can update increase the number of ingredients we're using for patch testing. Because the time taken is the same. So instead of 20, we can have maybe 25, 30, which might be more helpful to do, easier to do, and get more information. So in conclusion, I think the awareness should be there that whatever we are seeing, if there is non-responsiveness of the condition, we should consider that maybe there is some contact allergen. You should be interested and look at this angle. Knowing the local customs and cultural phenomena often gives us clues to what could be causing the allergies. So do the patch testing and record, because we hardly have, I think, handful in whole of Hyderabad who do patch testing. And when I inquired for records, almost all of them just, I think, write for the patient what's positive and send. So we don't have any database. There are only, I think, institutions, especially teaching institutions and PGs do this for their theses, and that's the end of it. So I think more institutions to take it up and bring out more of this patch testing, or have a routine patch testing facility and collect information on that. And also we should know what medications we're using thoroughly, the topical medications especially, because what it contains, not only the major ingredient, but what preservative, what vehicle could be causing the problem. Because when you're suspecting contact dermatitis, then you should avoid anything which contains the possible allergen. So this is how I think we should be more interested in contact dermatitis. And then carry this forward. I hope this meeting, this webinar will help you to get more interested in it and also give direction as to what you would like to do about it. Thank you very much.
Thank you, madam, for the wonderful introduction. Still, I feel contact dermatitis is an enigma. Understanding its pathogenesis is difficult, and sometimes whatever tests we do, patch test or whatever it may be, we could not able to find out the allergen. So today we are having eminent speakers and academicians with us to discuss about this contact dermatitis, allergic contact dermatitis. So hope we will learn many new things from them. So now I request Dr. Malati Muniswamy to talk about patch testing. Dr. Malati is associate professor in JIPMER, and she completed her MD in 2011, and she has many indexed publications and book chapters, and many. She also has many grants, and her area of interest is pediatric dermatology and also chronic urticaria, immunodermatology, and STI. We are very happy to have Dr. Malati with us. Dr. Malati, please carry on.
Ma'am, please unmute, ma'am.
Am I audible now?
Yes, ma'am, yes.
Yes.
Good evening, all. I thank the organizers for giving me this opportunity, and without taking much time, I'll go on to the topic, that is patch testing. As per the words of, as per the words of Fisher, the man who has done enough work on contact dermatitis, he said that in a diagnosis of a patient with contact dermatitis, everything under the sun, including the sun itself, and all the agents which the patient has been exposed for years without prior difficulty needs to be investigated. And this includes the patient's entire environment comprising of the flora, fauna, topical medications, clothing, cosmetics, and other contactants which the patient is likely to encounter during work or as hobbies needs to be investigated. And this is important, and knowledge of all the possible inciting agents should be given to the patient so that he is able to differentiate between what causes the reaction and what is safe for him, so that he lives a safe life. So this is in just about what Fisher describes about investigating the cause for contact dermatitis. So to help with this, the most important aid that we have in our hands is the patch testing, which is the most reliable method of identifying allergy due to type 4 hypersensitivity. It is an in vivo test which aims to reproduce the elicitation phase, which producing the reaction to a contact allergen in a controlled environment. However, though it seems like a simple test, it requires sufficient experience, training, and knowledge, not only in performing the test, but also in interpreting the results and identifying the clinical relevance. So why is there a reluctance among dermatologists to do patch testing? First thing is probably the time-consuming procedure. Second is the patient might need to frequently visit the dermatologist for the patch test reading, or there is suitable patch test materials are not available, and the feared risk of complications. However, all these issues can be addressed well. That is, the time required versus once we confirm the patch test allergen, that gives a confidence for the dermatologist to proceed well ahead with the treatment for the patient. The frequent visits required by the patient may not be actually a problem to the patient, because the patient might feel comfortable that sufficient efforts are being taken to investigate the cause of his condition. And also, once we identify the allergen and avoid the allergen, the patient's disease activity comes down, and that proves to be cost effective. And regarding the availability of suitable test materials, now many patch test series and different techniques of testings are available. And regarding the risk of complications, the guidelines regarding testing and methods to avoid complications have been well established and have been published. And research has shown that patch tested patients have better outcome in terms of reduced disease activity as well as severity. And it was found to be most cost effective, especially for dermatitis, which lasted for 2 months to 1 year. So coming to the indications for patch testing, any patient who has a suspected contact dermatitis, it could be acute or a chronic dermatitis, and it could be of any morphology, be it dyshydrosiform, be it vesicular, be it eczematous, lichenoid, any type of contact dermatitis, and dermatitis related to any occupational exposures, and any type of dermatitis, that especially the chronic ones which are not improving to treatment, or are frequently recurring or have a change in the pattern. For example, atopic dermatitis, which follows a different pattern, always suspect contact dermatitis. And also not to forget the various other type of non-eczematous contact dermatitis and the various mucous membrane eruptions. So rather than contraindications for patch testing, I would say what are the conditions where we like to postpone the patch testing, because there is nothing like an absolute contraindication for patch testing. It's about only postponing patch testing at a later date. So one is when the patient is having an acute or a diffuse eczema, because there is a risk of false positive excited skin syndrome, wherein if a patient with an acute eczema can show false positivity in all the tested allergens. So for that fear, we need to postpone patch testing. And patients who are on systemic steroids and immunosuppressants, or who have applied topical steroids to the site of application of patch test. In those conditions, we need to wait till we apply patch test. For example, if the patient has applied topical steroids on the back, we need to wait at least for 7 days before we patch test the patient after stopping steroids. And if the patient is on any systemic steroid or immunosuppressants, we need to wait for at least 5 times the half-life of the drug to consider patch testing. This is because the patient may have decreased response in view of the immunosuppressants. However, with regards to systemic steroids, a patient can be patch tested if the patient is on 15 to 20 milligram of prednisolone. And in the tropical countries like us, where the high environmental temperature or humidity is high, there is a chance that the test material can be detached. So that doesn't mean that we cannot patch test. It is that we need to take adequate precautions regarding when to patch test. We should not patch test the patient during the height of summer when the patient has excessive sweating and the patch test material is likely to be dislodged. And exposure to UVB and UV rays. For example, a patient had an excessive sun exposure to the back, and especially recently the patient has so much tanned, then the patch test reactivity will be less. So we need to wait for at least 4 weeks after excessive sun exposure. Now coming to the technique of patch testing. So before we go into the procedure, we'll see what are all the materials that are required for patch testing. First thing is the allergen, also known as the hapten, which madam had described. So these haptens are available as individual haptens as well as series. And these patch test series or battery of allergens we call can be based on the type of allergens that are tested. For example, we have metal series, we have plant series, we have leg ulcer series, we have corticosteroid series, medicament series, sunscreen series. So a group of allergens, common allergens based on the condition or based on the application. Then we have national series, which are based on the specific allergens particular to a specific country. We have the Indian series, European series, Australian series. So in India, as per the CODFI, we have 3 series. One is the Indian standard series, which we all are well aware of. Then we have the Indian footwear series, and we also have the Indian cosmetic and fragrance series. These are the common Indian series. Apart from this, if we want to do a comprehensive patch test for a patient, apart from the Indian standard series, we can go for the individual series. For example, a patient's presents with venous eczema, and a patient has a non-healing ulcer, and we suspect allergy to the topical medications that are being applied to the patients. Then we can do a patch test, the Indian standard series along with the leg ulcer series. A patient whom we suspect sunscreen allergy. So we can also include sunscreen series in the along with the Indian standard series. So this is how we do a comprehensive patch testing. And sometimes we do what is known as an integrated series testing. Integrated series testing is we do the basic Indian standard series. Along with it, we just include 1 or 2 allergens which we suspect. Either we include a series as such, or we can include 1 or 2 allergens that we suspect. So coming to how we apply these allergens. Now we have these allergens, and these allergens need to be applied in a chamber. And those chambers have to be stuck on the back to elicit the reaction. So these chambers have specific materials which are designed so as to avoid sensitization to their own materials. So the commonly used chamber, which all of us know is the fin chamber, which is the Epitest Finland, which comprises of a circular aluminum chamber which is stuck on a Scanport tape, and this Scanport tape is also hypoallergenic. Then we have the IQ chamber, which is provided by the Chemo Technique from Sweden, which are square-shaped polyethylene foam chambers. The advantage of the IQ chambers is it has filter paper incorporated along with it. When we use the Finch chamber, for all the solid allergens, we just need to place the allergen on the Finch chamber. Whereas the liquid allergens, we need to dip them in a filter paper, and then we need to attach the filter paper. Whereas in the IQ chamber, they have an inbuilt filter paper which is incorporated, to which the allergen can be added. And in addition, the IQ chambers will have a rim at each chamber which has an adhesive layer. So it has a better adhesive potential. And the advantage of an IQ chamber is it has a plastic sheet with it, so we can also pre-fill the chamber. For example, the nurse who helps with the patch testing can pre-fill the chamber at least 2 weeks in advance, so that once the patients come, they can just stick off the patch test material. which is not possible in a Finch chamber. And the recent chamber is the IQ Ultimate, which has come with special material so that it is water resistant, elastic, and transparent. So it is very patient friendly. So patient need not avoid taking a shower when patch test is being applied. So coming to how these haptens are provided. These solid haptens are preloaded in a polypropylene syringe. And when we apply this allergen into the chamber, we make sure that we apply only 4 to 5 millimeter, or the sufficient quantity which just covers a little more than that of the chamber size. That is the amount of solid haptens that we are supposed to apply. When it comes to liquid haptens, they are available in plastic vials, and just 1 drop of the allergen in the filter paper has to be applied and has to be put into the chamber. Then there are ready-to-use tests known as the true test, but which are already pre-filled, and we just need to apply it over the patients. But these tests are highly expensive. And being in tropical country, we need to remember certain things. These haptens might get disintegrated when kept at a high temperature. Hence, we should always store these haptens at 4 degrees, except for wool alcohol, where it needs to be sold at room temperature because it will get solidified. And while applying the various haptens, we should be very careful that we do not apply haptens which provoke strong reactions side by side, because they might result in one reaction in one can result in a reaction in another, and non-specific reaction in all the other patch test reactions, resulting in angry back syndrome. And as I told earlier, we have the standard battery series and we have the integrated series, where along with the standard series, we incorporate 2-3 haptens, and we have additional series, whereas like the leg ulcer series, sunscreen series, cosmetic series, which can be added to the standard series. So testing with all these kind of series is known as comprehensive patch testing. And the decision on what series we need to use depends on the patient's clinical history. Now, we also need a skin marker, because the routine markers which we use may cause irritation and allergy. They may also cause irritant reaction, or sometimes they can be just washed off. So there are specific skin markers to mark the site of patch testing. So we have the chemo skin marker regular, which is a specific material, methyl row, aniline and silver nitrate, which is non-allergenic. The slightly modified one is with a narrow tip, and we also have the UV marker. For example, this is not visible, so it is more patient friendly. And when you mark it, you need to identify the site of marking using a UV lamp. And coming to the site of application. So the preferred site of application is the upper back. The lower back is not preferred because it is less sensitive and there is a high chance of false negative reactions. So coming to the site of application of patch test, it is this border formed by the scapular spine beyond the posterior axillary line, and then the vertebra and the 8th and 9th thoracic vertebrae. This is the site where we are supposed to apply the patch testing. If for any reasons we cannot apply it on the back, for example, the patient has applied topical steroids to the back, or patient is having extensive folliculitis or acne, then we can use other sites like the extensor surface of the arm and anterior surface of the thigh for patch testing. Also in children where the back is small, we cannot apply all the allergens. Apart from applying patch test allergens on the back, we can also choose other sites like anterior surface of the thigh and external surface of the arm. But we should be careful that there are no skin lesions at the site of applications. The hair should be shaved prior to patch testing, either with an electric laser. And when we shave, we should be careful not to use a shaving lotion or cream, because they themselves can cause allergic or irritant reaction. And if the patient is having oily skin, it can be cleansed with ethanol or acetone. And take care not to apply patch test over moles or any benign tumors like seborrheic keratosis and all that, which have a potential to undergo irritation. Now coming to the instructions we're supposed to give the patients prior to patch testing, we should tell them not to bath or shower for 48 hours till the patch test is applied. They should avoid vigorous movements so that the patches do not get detached. They should avoid any exercise or activities that will provoke sweating. They should avoid sun exposure. No scratching. Even if they have a tendency to itch, they should never scratch the lesions. And if the patch is detached, they should just reapply. They should stick it with the external micropore tape and come to the clinic and where it has to be reapplied. And also we should tell the patients that there is a chance that the patient's dermatitis might flare up while the patient is being patch tested, just in case the patient had a subacute eczema. And if the patient has a very intense local or general reaction, he has to immediately visit the clinic. So coming to the patch test procedure, we have a small video here. So these are the agents that we require: the Finch chamber with the scan pore tape. Then we have acetone to degrease the skin to remove the oil. Then we have filter paper, micropore tape, and 4 glass slides. I'll tell you why we need the glass slides. And then we have the loaded haptens in the polypropylene syringes. So we remove the fins chamber and we attach those 2 glass slides at the margins of the strips. This is because this will help us in better adhering the patch test strips to the back of the patient. And once we attach the glass slide, we need to number the strips from 1 to, we have 20 allergens, so we need to number them. And then using this pre-filled syringe, we need to apply those allergens into the chambers. And as I told earlier, 2 to 5 millimeter or little more than the size of the chamber we are supposed to apply. Half of the chamber we are supposed to apply. So once these allergens are applied into the chambers, we need to degrease the skin of the patient using acetone. And then at the described location, with the help of the glass slide, we have to stick it from below upwards, and so that it adheres properly without any trapping of air and without any creases. So the use of the glass slide is to enable proper adhesion of these strips to the back of the patient. And then you secure it properly with the help of micropore tape. Micropore tape is also hypoallergenic. So once the scanpore tape is stick, we need to adhere it properly with the help of a micropore tape. And then again renumber the allergens. Then after 48 hours, the patient is asked to come for a reading, and then the initially the micropore tape is removed, and then the scanpore tape is removed. And once you remove it, you need to mark the site of the allergen and number them. Because immediate reading is not done, the patient is asked to wait for at least 15 to 30 minutes so that all the pressure effects go off, and only after 30 to 45 minutes the patch test reading is done. So the patch test reading has to be done by a dermatologist who's well trained and who's well experienced in identifying the reactions. Adequate lighting is very, very important, and especially is preferable if there is an adjustable side lighting. The reading ideally has to be done on day 2, and a second reading should be done at 72 to 96 hours also. This is the most clinically relevant reading, because many reactions which are not positive during the second day might be seen in the 72 to 96 hours. And certain allergens will show late reaction, and for those allergens we need to do a reading at 5 to 10 days, preferably on the day 7. And as I told already, once the patch test panels are removed, all the marking should be redone, and the reading should be done only after 30 to 60 minutes, because the pressure effects needs to resolve. And for grading the standard the reactions, we follow the International Contact Dermatitis Research Group's scoring system. So these are the allergens for which early reaction occurs. For example, balsam of Peru, thiuram, makes wool alcohols. We expect an early reaction within 24 hours. Whereas the ones for which we need to do definitely a 5 to 7 days reading are fragrances, preservatives, dispersed dyes. And for 7 to 10 days, especially when we suspect metal allergy, topical antibiotics, preservatives and glues, PPD, we should always definitely do a 7 to 10 day reading. So coming to the grading of patch test reading, this is how we are supposed to depict the patch test reading. So we put a minus symbol if there's no reaction for a negative reaction. For a doubtful reaction, a query with a positive symbol, which means the patient has only faint erythema. So it is only a doubtful reaction. And 1 positive where patient has erythema infiltration and papules, just few papules, and it is a weak positive reaction. 2+ when there is erythema infiltration papules with vesicle formation. It means a strong positive reaction. An extreme positive reaction, the vesicles will be coalescing to form large bullae. And irritant reaction is, apart from all these papules, vesicles, we'll have other morphologies like bulla, necrosis. Then we need to consider the possibility of irritant reaction. So this is how we grade a 3+ reaction. That is an allergic reaction. We see in all these things, patients are having erythema, infiltration. That is when we palpate and see, we'll be able to identify the infiltration. So there is erythema, papules, predominantly vesicles, and bullae formation. And we find that the reaction extends beyond the margin of the patch test site, and they are homogeneous in appearance. Again, the type 2-1, we are not finding classical bulla or few vesicles are there, but again, they are homogeneous and extending beyond the site of application. And the 1+ reaction, where they're just partially extending beyond the site of application and they are homogeneous, and it's predominantly erythema and edema, and we'll be able to find just few papules. Whether it is ACD 1+, 2+, or 3+, the second reading when we do, there'll always be an increasing severity of the reaction. Now coming to a doubtful reaction. Whenever we find just a patient doesn't have symptoms or only mild pruritus, and it is a distinct margin which does not extend beyond the contact area. The lesion can be homogeneous or non-homogeneous, and it's just plain erythema. It is a doubtful reaction and it is ideal to go for a repeat testing. Sometimes we find a mixed reaction where we have both allergic and irritant contact dermatitis, where patient will have a faint margin. It can extend beyond the margin or it can be well defined to the area, but we'll have various morphology, especially pustules. Presence of pustules, you should always consider that there is a mixed reaction or an irritant reaction. Then a whole lot of false positive manifestations can be present. What we call as the soap effect, that because of effect of the soap and shampoo, these result in chapping of the skin, resulting in desquamation and presenting with skin creases. That is a soap effect, or a border effect due to compression by the patch test margins and presence of pustules. Then that is an irritant reaction. Presence of only pustules is a irritant reaction. Presence of folliculitis, that is also a false positive reaction. So a false positive reaction, we should always do a repeat testing, and when we do a second-day reading, it will always show a decrease in the severity reaction. These are all the various false positive reaction: a border effect, a soap effect, purpuric lesions, or presence of pustules. Malaria, because of the occlusion, patients can have malaria. That is also a common problem. Without formation of vesicles coalescing to form bullae, direct bulla formation, or follicular lesions, necrotic lesions, all these suggest irritant reaction, and they are false positive reactions. So by false positive reactions, we mean they are predominantly irritant reactions. So we need to differentiate them from an allergic response. False positive reaction usually occur within few hours. And as I told, the second reading done at the 5th day will always show a regression of the severity, in contrast to a positive allergic reaction where there'll be a worsening severity. And an allergic reaction will have pruritus, whereas a irritant reaction will have burning sensation. There'll be skin thickening. That is, the induration will be felt in a patient who has a positive allergic contact dermatitis, which may also always not be present in an irritant dermatitis. And the margins always extend beyond the site of application of the patch test allergens, whereas in an irritant reaction, they're usually very well defined. And they are homogeneous in case of allergic reaction, whereas non-homogeneous in an irritant reaction. The patient might have a flare of their reaction in case of allergic reaction. And when we test with the same concentration on a control population, an allergic reaction will be negative, whereas a irritant reaction is always positive even in the controls. So the reasons for the various false positive reactions are when insufficient hapten concentrations are, the quantity of hapten applied is also high. Then we have false positive reactions, and also the method employed. For example, the patient has too much of occlusion, or there's a partial detachment. All these can result in false positive reactions. We fail to apply it on the upper back, then, or apply it over areas where the patient already has a dermatitis. Then there can be exaggerated false positive reaction, or excuse me. Sorry, I'm talking about the false negative reaction. When we have an insufficient hapten concentration or low quantity that is applied, that is a patient who has contact allergy but does not show positive on the patch test. So for these, that's insufficient hapten, or the method applied. You do not apply it on the patient because of vigorous activity and sweating. It just gets washed off and there is detachment of the patch test strips. And we do not apply, for example, we apply it at the lower back, and we do not have the proper series. The choice of choosing the allergens was not appropriate. Or for example, some allergens require irradiation by UV rays to produce the reactions. For example, patients who have photoallergic contact dermatitis. So a photo patch testing will be required in those patients. And patients who are on steroids, or who have a low tendency to develop or on chronic immunosuppressants. So in such patients, you can have a high false negative reactions, and also exposure to UV rays. So coming to the various adverse effects of patch testing. The first adverse effect which we are worried about is the active sensitization from patch test. Those patients can have flare-up of the patch test site, which can occur at 10 to 14 days. This is possible because when high concentration and amount of allergen applied, or the patient has applied the patch test for a long duration. The patient didn't come for reading in the second day and didn't remove the patch test. When there is a long duration, you can have active sensitization. Then irritant reaction. When we have used a high concentration, then we expect irritant reaction. There can be an ectopic flare of dermatitis. A patient who had his dermatitis resolved can have a flare-up of his dermatitis once patch test is done. Hubner phenomenon. A patient who has psoriasis or lichen planus, when we do patch test, there can be development of psoriasis in the site of patch test sites. Or the patch test reaction can persist. This is common with gold allergens. altered pigmentation, which we commonly see with PPD or hydroquinone. Hydroquinone will cause bleaching effect and PPD will cause hyperpigmentation. And pigmentation is a problem with dark skin individuals and in individuals who commonly get exposed to sunlight, or also healing of irritant reaction. Anaphylactic reaction is very, very rare with patch testing. However, it can occur. Patients might develop these reactions within 30 minutes of applying a patch test because of non-specific histamine release, which is common with antibiotics and ammonium persulfate. So other adverse effects are, whenever there is excess irritant at the periphery, there is edge effect, whereas the reaction is prominent at the edge rather than in the center of the reaction.
Sorry, Dr. Malati, how much time you require? I think.
Ma'am, another 5 minutes, ma'am.
Yeah, please carry on. Please wind up fast.
Pustular reactions, which are common in atopics and with metals, pressure effects in patients with dermographism, infections, especially when we use indigenous products, necrosis, milia, and angry back syndrome. So this is a picture of a patient with excited skin syndrome. So there are other techniques of patch testing, that is photopatch testing to detect photoallergy contact dermatitis, where after patch test application, we need to irradiate with UVA. We have the semi-open test where we apply the allergen with a cotton swab and occlude it. That is applied over 1 centimeter area of the skin. Then we have an open test without occlusion. We apply the allergen over 2 centimeter square area of the skin. And we have a repeated open application test where we ask the patient to reapply the same products for continuously for 7 days on a healthy skin to see if the patient develops the dermatitis. So once we have patch tested the patient, the important thing is about the clinical relevance. So the clinical relevance can be classified as definite, probable, possible, and past. So definite is a patient having a positive patch test to his own reaction. To his own agent, that is definite relevant. Probable is the patient's patch test is positive and the patient, whatever material the patient comes in contact, that material has the same allergen. Possible is patch test is positive and the patient has a contact with lot of all the agents which can contain those possible allergens. And past is patient has a past history but doesn't have the relevance right now. So there are certain pitfalls in the clinical relevance. That is, we fail to elicit a detailed history. We fail to elicit history about the volatile substances in the environment of the patients. And patients, substances used by the patients needs to be retested, and delayed reactions, that is 5 to 7 days reaction has to be tested, and impurities are also not assessed. So once the clinical relevance is established, we should give the patient a list of products which contains all the allergens so that the further exposure is avoided. And it is also prudent to give a safe list of alternative products that do not contain those allergens. So these are examples of relevant patch test reaction to a patient with PPD, dye, a child with orange colored footwear and dispersed orange dye, and patient's own footwear is positive. So coming to allergens over the decades, the American Society of Contact Dermatitis always comes out with the allergen of the year every year based on the most frequent reporting. So this year it is isobornyl acrylate, which is commonly present in all these artificial nails, and for us it's of relevance in medical devices. So we should look into all these allergens of the year and try to incorporate all these allergens into our Indian standard series. So to conclude, it is important to patch test all individuals with the persistent eczematous skin conditions, at least to exclude the possibility of allergic contact dermatitis. And patch testing should be done to a location-specific series of commonly contact allergens, and also series which are relevant to exposure, and they should be appropriately diluted patient's own products. So patch testing is both an art as well as a science, and we need to follow the Sherlock Holmes-like approach to identify the allergens which cause these reactions. Thank you.
Thank you, Dr. Malati, for the excellent insights on patch testing. Thank you very much. Now I would like to invite our next speaker, Dr. Jyotsna Gampa. She is the interesting topic. She is talking about skincare products and topical medication. So that is very interesting topic because skincare is our day-to-day regular thing. What we do, what we are using many creams for the skincare routine is a very, very important thing. So if we develop allergies to these, so will be discussed by Dr. Jyotsna. How to identify.
Thank you, Dr. Sudha.
Dr. Jyotsna is a well-known dermatologist. She is running her Chaitanya Tricho Dermatology Center, and she is academically very interested, and she is having 15 years of experience And she conducted many workshops on anti-aging treatments and also thread lift in association with TSIADVL. Carry on, please carry on.
Thank you, Dr. Sudha, for introduction. Thank you, TSIADVL, for giving me this opportunity. So my previous speakers, as they mentioned, they have made my job easy. They have explained clearly the pathogenesis of the dermatitis as well as the patch testing. So being a practitioner and as a dermatologist, see, we might be encountering number of patients who might be coming to us with a contact dermatitis. So we will be evaluating for them. But skincare products and topical medications, these are the medications which we will be sometimes prescribing to the patient. So we should be more aware of the allergens or common reactions to these medications, and how to prescribe them, or how to identify and how to guide a patient. Sometimes patient might develop reactions to the products which have been prescribed by us. So we should be aware, we should be more vigilant about the common allergens. So allergic and contact dermatitis skincare products, common products like cleansers, moisturizers, sunscreens, shampoos, and hair dyes, and something unique to the Indian community, the bindi dermatitis. I'll be discussing a few points on these things. So among all the other skincare products, cosmetics, and the medications, whatever we use, fragrance tops the list of allergens. Fragrance form the almost 50% of the allergens, which are the cause for the either to the irritant or both allergic contact dermatitis. So one point I want to highlight is sometimes some products they mention as no fragrance, but no fragrance doesn't mean that it is a fragrance free. No fragrance sometimes can have a minor amount of hidden fragrance in that, which is just added to mask the effect of that ingredients. So always be vigilant about this thing. You should inform the patient to check with the no fragrance or a fragrance free products. So no fragrance is something different from fragrance free product. There is a fragrance panel as discussed by Dr. Malati madam, which tends to evaluate the reason, the cause of this fragrance allergy. But at the same time, there are so many new fragrances which are in the community. Sometimes it can be a mixture of fragrances. So I always advise, apart from the fragrance panel, we should test the product, which is the suspecting product from the patient basket also. Coming to the next in the list, apart from the fragrances, is the preservatives. These are at the second in the list of allergens. The common parabens, formaldehyde, formalin, then quaternium 15. So many preservatives are there. These are added to extend the shelf life and to prevent rancidity. So it is compulsory to add a preservative in either the cosmetic product or the medication. So we need to be vigilant regarding these things. So whenever we get allergen to a preservative, we should be able to guide a patient or redirect a patient to use a product which has a different preservative in that. So always we should be knowing the common preservatives. Parabens are the commonly used preservatives, though comparatively the incidence of allergy the number of products containing the parabens and the incidence of allergies, though it is less, but the chances of allergen to the paraben is also there. Formaldehyde is comparatively more allergic. And quaternium 15 is a newer molecule which is used mostly in the cosmetic products. So we should identify these products and suggest a different product to the patient. Then the colorants, any color, but yellow, red, and carmine, these are the colors which are more allergenic. So whenever we are prescribing a product to the patient, or whenever a patient complains of allergic reactions, we should use a colorless product, a fragrance-free product, and a preservative. It will be there, but probably we need to choose a preservative which is less allergenic. So sunscreens, we all agree sunscreens are used widely nowadays and prescribed widely. It became mandatory for all of us to use a sunscreen day to day. So the allergic reactions to sunscreens have increased. A common contact dermatitis due to allergic reactions, it has a one more it causes photo allergic reaction. At the same time, we will be prescribing sunscreens mostly to the photodermatitis. So we should be vigilant whether the reaction is an aggravation in the existing photodermatosis or an allergy to the sunscreens.
So the allergy to sunscreens can be either due to the vehicle ingredient in itself, the bases used for sunscreen, or the fragrance. So patch testing for the sunscreen should include it should be done to all the ingredients, including the standard series, standard battery series, and to the product bought by the patient. So manifestations, there is a different in photo, since the manifestations of sunscreen are photoallergic reactions. Reactions will be seen mostly in the treated sunscreen applied areas which are only sun exposed, but the parts like the upper eyelid, submental area where the sunscreen is applied but have not been exposed to the sun are usually spared. And sometimes the reactions can be asymmetric, which can be like probably the exposure sides of the window or the driving seat side for a patient who drives the car. So this helps us to differentiate the reactions, either they could be because from a sunlight or the ingredient itself. Rarely it can also cause severe reactions like contact urticaria and anaphylaxis, as been previously described by Dr. Vani Madam, where different manifestations can happen. So allergens, common allergens in sunscreens are PABA and its esters, cinnamates, which are mostly used in water-resistant-based sunscreens, avobenzene, which is the only UVA sunscreens most frequently used nowadays, benzophenols, octocrylene. Octocrylene has been shown to have allergen reaction even in children. So just check whenever you are prescribing a sunscreen to a children. It should be free from octocrylene product, tinosor. So whenever you encounter a patient who has an allergic reaction to sunscreens, try to prescribe mineral sunscreens like zinc oxide and titanium dioxide, which do not cause any contact dermatitis. The nano formulations of these sunscreens have really helped us in prescribing in a most cosmetically elegant way. Then the uniqueness of a sunscreen patch testing is at the photo patch testing, which has been elaborated by Dr. Malti ma'am. Here we apply duplicate sets of allergens, and one of the sets is irradiated with a 5 joules of UVA energy after 48 hours of occlusion to see whether there is a photoallergic reaction. Sometimes patients with allergic reaction, they do not react to any single sunscreen agent, because we always see a commercially available sunscreen agent has a mixture of sunscreen ingredients. So sometimes it will be difficult for us to differentiate the allergic reaction to which product. So you can test the product as of itself and check the ingredients in that when you are not able to elucidate reaction from a battery of ingredients. Next, coming to the cleansers. Cleansers are one of the common products, and we see with the increase in this pandemic era, the usage of cleansers has increased compared to other products. So these cleansers are one of the allergy to cleansers is commonest reaction to even hand dermatitis also, apart from the reactions on the face. Increase in the cases of hand dermatitis in the pandemic is due to the increase in use of allergens, which causes irritant contact dermatitis, as well as allergy to the cleanser ingredient, which causes allergic contact dermatitis. So the common allergens encountered in a cleanser are quatinium 15, cocodamopropyl betaine, then fragrance mix, myroxylone perine, 4-chloro-3,5-xylenol, amidoamide, formaldehyde. So among these things, again we have seen here the fragrance mix, the quatinium 15, which are used as the preservatives, and these are the major ingredients apart from the other allergens. So coming to moisturizers, sometimes we encounter a reaction to moisturizer itself, which we commonly prescribe to any of the children or adults. So usage of moisturizers also become universal, and with increasing in the extremes of the winter season also, the usage of moisturizer has become it has increased. So various components of moisturizers which elicit this allergic contact dermatitis, again it is fragrance, which occupies a majority. Then coming to the parabens, then vitamin E, sometimes the essential oils and biologic additives also. We have seen sometimes the addition of the tea tree oil, which is more cosmetically acceptable, and this addition of these oils and bio oils, all these things are also sometimes they are the reasons for this allergic contact dermatitis. Benzyl alcohol, the propylene glycol, which are used as bases, then the preservatives, then the lanolin, xanthan CG, all this can be the reason for the allergic reaction to moisturizer. So whenever you're prescribing a moisturizer, check for the ingredients. Particularly in baby products, the allergy to the lanolin and propylene glycol have been seen. Then whenever we have the allergy to the fragrances, so try to choose a product which has less of these ingredients. So whenever a patient complains of allergic contact dermatitis to moisturizers, plain petroleum jelly can be recommended, or the product that only contains, instead of a mixture, only a paraben, a single paraben sometimes can be prescribed. But as such, parabens are also one of the causes for allergic contact dermatitis. So hair shampoos, we all know the sodium lauryl sulfate free shampoos are nowadays prescribed to prevent allergic reactions, particularly in patients, in children, and who have atopic tendencies, and routinely also who have complained of allergic contact dermatitis. So again, the component of the perfumes, the sodium lauryl sulfate, anti-dandruff agents like selenium sulfide, zinc pyrothene, the preservatives like lanolin, and surfactants. The shampoo had the surfactant and solvents dissolved in this. So any of these products can be the reason for allergic contact dermatitis. So we need to differentiate with a patch test what is the reason for this reaction to this shampoo, and be able to suggest an alternate to it. Coming to hair dyes and sensitizers in hair dyes, this is an increasing reaction we encountered nowadays, and the awareness is, I feel the awareness is very less in the general public, though in many of the countries the paraphenyl diamine is banned. In India it's widely used, and so it's one of the main reasons acting as a sensitizer in hair dyes, apart from other sensitizers like para-toluidine diamine, para-aminophenol, amino, and additives like pyrogalol and resorcinol. So usually the hair dye reaction is allergic reaction seen on the upper eyelids, forehead, scalp, and rarely sometimes onto the neck and upper extremities also. So sometimes a reaction due to contact sensitivity, a depigmentation reaction to a hair dye is also seen. Just like we have seen this patient, it extends onto the from the scalp, it extends onto the margins beyond the scalp margin. So here also patch testing is required. Here an open patch test or a photo patch test can be done to diagnose allergen. Then one of the unique reaction which is seen only in Indian population is a reaction to either a kumkum or bindi. Bindis are the plastic materials which has a PVC and an adhesive like a paratertiary butylphenol. So a contact dermatitis can occur either to any of these reactions, like a colophony, abitolol, or monobenzone. A depigmentation of the skin can occur in this reaction, or it can be an allergic vesicular reaction, or sometimes we see a lot of lichenoid reactions on the forehead region extending till the scalp. So patch testing is here done either with an adhesive side down of bindis. And one more reaction we see is a kumkum. So there are many studies done on this kumkum, which is also unique to the Indian community. So I have taken this topic to discuss today. It has a brilliant lake red, sudanite, aminobenzone, and fragrances, groundnut oil. And this is sometimes a chandan and a paraben added to these things, tertiary hydroquinone, chalk powder. So and turmeric also. So whenever there are studies which show that patch testing done here have shown reaction to all these ingredients. So before suggesting an alternate to these people, we should be able to do a patch testing and suggest alternate to these people. The red colored powder sindoor, it contains mercury and black pastel lead sulfide. So these are some of the reactions of the bindi and kumkum extending onto the forehead region. So this is a reaction which is unique to Indian community, which is not only related to, it has an additional emotional component attached to this thing. So patients always seek for an alternate, since it's an emotional component attached to that thing. So we should be able to prescribe an alternate component. There are some vegetable dyes available in the market which have been prescribing to the patients. Then coming to the medication part, apart from the cosmetic unity, medication, the commonly used medication which we use in our day-to-day practice is a topical corticosteroid. So usually we prescribe a corticosteroid as a treatment to this allergic dermatitis, but sometimes we develop allergic reactions to these topical corticosteroids also. So when the topical first case was reported by Booker, so initially they started using the topical corticosteroids in 1954, but within 4 years they have noted that they are developing allergic contact reactions even to the topical corticosteroids. And the easy availability of double and triple combination creams in the market with a mixture of antifungals and hydroquinone, these have increased the exposure rates to these topical steroids, increasing the incidence of topical corticosteroids. But probably the patch testing reactions, what we are doing to diagnose these topical corticosteroids is very, very low. So high index of suspicion is required by all of the physicians to detect this topical corticosteroid-induced allergic dermatitis. Always suspect when a chronic dermatitis, especially recalcitrant one on lower legs, hands, face, is worsening with your prescription of topical steroids, and it's either failure to clear or exacerbate. And sometimes it can also manifest whenever you are prescribing the topical corticosteroid. It manifests like an eruption or an EMF-like reaction at a distant sites. So always suspect. A high index of suspicion is required, and more awareness is required for this allergy to the topical corticosteroids. There are different classes of topical corticosteroids based on their chemical structure. Class A, B, C, and D. A includes hydrocortisone and ticocortisone. B, triamcinolone. C has a beta-methazone type, and D has a hydrocortisone 17 butyrate and clobetasone 17 butyrate. So here the studies have shown that the classes of topical corticosteroids not only cross-react within the group, but they also cross-react with other groups. So comparatively, the cross-reactions between A, B, and D groups are more. So a class C can be chosen as an alternative whenever you encounter an allergic reaction to any of the other class of drugs. So patch testing to topical corticosteroids is slightly tricky here. So here also it can be either allergic reaction due to the preservatives or the penetration enhancers or any other additives, or sometimes it can be just to a package like a nickel tube from which a topical corticosteroid is stored over there. So a standard battery series should be applied along with the suspecting corticosteroids. Since the reactions here are delayed, it's more important to take a reading on the 7th day, which picks up most reactions which are negative within the 48 hours and 72 hours duration time. So, and other most common drug which we encounter in a day-to-day life is the neomycin, most widely used OTC preparation, I can say it as, or like with the common practitioners. It has a neosporin, the triple antibiotic, which is commonly used as a neomycin as an ingredient along with other antibiotics like a polymyxin, bacitracin. So it has a wide, huge market in the OTC preparation and commonly used. It also acts as a sensitizer and leads to allergic reactions. So neomycin is found in hemorrhoid creams, OT, ophthalmic preparations, and including the topical steroid mixed antibiotic preparation combinations. So it can also have a co-reactivity with bacitracin and a cross-reactivity with aminoglycosides. So always bear in mind the reaction to a neomycin most commonly encountered, particularly in lower leg ulcers and stasis eczema cases. There is worsening with neomycin. Then other antibiotics which we commonly use like sodium citrate, mupirocin, clindamycin, erythromycin, in various dermatological conditions also have few reported cases of contact dermatitis. Then bacitracin, this also we have already seen, it has a reaction along with the neomycin. Then other commonly used, povidone iodine, we all agree, we use it before any procedure, it's a preparative for the skin preparation. So in day-to-day practice, it's used by all fields and all of us every day almost, and hand scrubbing and for the treatment of the skin preparation, it is a rare sensitizer. So individuals who are allergic to povidone iodine sometimes react to the injectable radioactive iodine-based dyes. So always warn the patient and inform the patient regarding these things whenever you encounter a case of povidone iodine allergy. And chemical burns due to prolonged contact or due to direct toxic effects or irritant effects are also seen with povidone iodine preparations. And next commonly used, antifungals. Now the fungal infections form 50% of our day-to-day OPDs. So antifungal creams also, some in our practice we encounter reactions to the antifungal creams. So apart from the preservatives, and what are the other antifungal ingredients as such which can cause allergic reactions? So among the imidazole derivatives, meconazole, iconazole, ticonazole, isoconazole can cause allergic reactions, and among the allylamines, amorolfine and naphthepin, they have the potential to cause allergic reactions. Terbinafine has comparatively less allergic potential, and ketoconazole also has comparatively less allergic potential. So these can be prescribed as an alternative whenever you encounter a reaction to this antifungal preparations. Then antihistamines, as topical steroid, antihistamines also used to alleviate the allergic reactions, but topical antihistamines as such, they can cause act as a sensitizer and cause reactions apart from the systemic antihistamines. Phenothiazines and ethylenediamines are used as topical preparations and are more likely to produce hypersensitivity reactions. In day-to-day practice nowadays, we see many of the combinations of moisturizers with topical antihistamines prescribed for atopic individuals and other preparations. But sometimes we encounter the worsening of their allergy whenever we prescribe these soothing lotions to treat such conditions. So always be vigilant about these things. Check for the allergic reactions to these antihistamines and try to go with a common ingredient. Then among the local anesthetics, lignocaine, sometimes it can have a topical lignocaine and prilocaine cream. Also, we encounter cross reactions with these groups. And benzocaine has a more potent sensitizer compared to the lignocaine and prilocaine. But cross reactions to other benzocaine, it can cross react with even PPD, PABA, and anti-diabetic medications. So whenever you are using a benzocaine as a topical preparation, be cautious regarding these things. And lipsticks, other cosmetic products, it has the dyes like DNC Red 21 eosin. It has the pigment solvents, antioxidants like vitamin E, sunscreens, lanolin, fragrance, so many other preparations which can cause lipstick reactions. Here, lipsticks also cause allergic reactions which are more prominent, like photoallergic reactions leading to darkening of lips. So just whenever you encounter a darkening of lips case, just check for the lipstick allergy and chapping of the lipstick. Chapping of the lips, it can be a differential diagnosis for your acne cheilitis. Just check for any lipstick allergy in such cases. So eye makeup and manicure products, shaving lotions, these contain alcohol, aluminum chlorohydrate. So shaving preparations is mainly due to aftershave lotions and perfume in that thing. So always patch testing for aftershave lotions and advice to avoid the patient. We encounter reactions which are differential diagnosis for your seborrheic dermatitis on the beard area, allergic contact dermatitis. So whenever you encounter such reactions, check for your aftershave lotions, any allergic contact dermatitis. Sometimes baby products also, wet wipes and the containing oils and lotions containing lanolin, preservatives, perfumes, so many propylene glycol preservatives. So all these are causes for the baby reactions in the baby products. So check for this napkin dermatitis and perianal rash, where whenever you encounter such cases, check for allergic contact dermatitis to such products. So I always at end of the session, I should feel like we should be more vigilant about the products which we are prescribing. At the same time, new products which are introduced into the cosmetic field as an OTC, because whenever a patient approaches us, we should be knowing the newer ingredients which are being introduced into the market. So as a physician, when we are aware of these products, we will be able to doing justice in treating a patient. Thank you for giving me this opportunity.
Thank you, Dr. Josna. Excellent inputs. So thank you very much. And unfortunately, our next speaker, Dr. Sukatan, is not joining us. So we will move on to the next topic, that is systemic contact dermatitis by Dr. Neetu Bari. Dr. Neetu is Associate Professor in AIIMS, Delhi. So she has 93 articles and 20 chapters in her credit, and she is an excellent academician too. And she got IADVL scholarships and many prizes in her credit. So her topics of interest are pediatric dermatology and dermatopathology. Dr. Neetu, please
Just gonna
carry.
stop sharing, no?
Ma'am, Joshna ma'am, please
Yeah.
Stop.
close your.
Okay, 1 minute. Okay.
Yes. Thank you.
Yeah, thank you.
So, good afternoon, everyone. At the outset, I would like to thank Dr. Sudhavani and Dr. P. Vani for giving me this opportunity. Today, I'll be discussing systemic contact dermatitis. So, systemic contact dermatitis, as Dr. P. Vani said in her introduction, that this is a type of contact dermatitis which developed following systemic administration of a haptane in an individual who has a pre-existing contact sensitivity. That previous sensitivity may be secondary to topical exposure, but the current dermatitis is almost always secondary to a systemic exposure of the allergen. If we talk about systemic contact dermatitis, it may result in dermatitis in the areas of previous exposure. That means previous dermatitis may be flaring up, or a previous positive patch test site may show flare up of the reaction. It may also result in dermatitis on previously unaffected area. That means a new onset vesicular hand eczema, flexural dermatitis may develop, baboon syndrome may develop, it may cause maculopapular rash, vasculitic-like lesion, and even urticaria and anaphylaxis. These cutaneous manifestations are also associated with general symptom of headache, malaise, arthralgia, diarrhea, fever, etc. Baboon syndrome is a type of systemic contact dermatitis where we see these erythematous eroded plaque in the interdigital, intergluteal, also in the various flexures like groin, axilla associated with periorbital erythema and edema. Baboon syndrome is also called as symmetric drug-related intertriginous and flexural erythema. In 2004, Hauserman gave the criteria for the diagnosis of baboon syndrome or symmetric drug-related intertriginous flexural exanthum in the form of that this is a reaction developing following an exposure to a systemic drug, resulting in a symmetrical involvement of intertriginous and flexural localization. Systemic symptoms and signs are usually absent in this form of systemic contact dermatitis. If we talk about etiopathogenesis of systemic contact dermatitis like or allergic contact dermatitis, this is type 4 reaction where we have both sensitization and elicitation phase. Various studies have been conducted and some of them are showing that in individuals who are sensitive to nickel, following oral nickel exposure, there was reduction in the number of T lymphocytes, CD4, CD8, even memory cell, which suggests that they have a role in the pathogenesis of this entity. Similarly, there was increase in the number of various cytokines and acute phase reactant in patients who are developing this reaction. And in some studies, they have also shown increased level of Th2 cytokines like interleukin 5, 6, and 10. If we talk about causative agent, food like balsam of Peru, which is the commonest food material causing systemic contact dermatitis, compositive plant, garlic, etc. Metals are the commonest causative agent in systemic contact dermatitis. Out of them, nickel is the commonest, followed by chromate, cobalt, gold, and mercury. And then we have various medications. These medications may be topical, may be systemic, and commonly involve antibiotics and anti-inflammatory group of drugs. We should also be aware of various cross-sensitizer to these agents, which may also cause similar manifestation in the individual who has a prior sensitivity. If we talk about nickel, which is the commonest agent responsible for this reaction, the systemic contact dermatitis to nickel is also called as systemic nickel allergy syndrome. Regarding its prevalence, a study was conducted in Italy where 2,000 patients were evaluated, and it was found that 5.78% of them had systemic contact dermatitis to nickel. So it is quite common. Various risk factors were mentioned as a patient having systemic nickel allergy syndrome, and those were piercing, occupational exposure, younger age, atopic dermatitis, joint diathesis, leg ulcer, etc. Systemic contact dermatitis to nickel may cause systemic contact dermatitis manifestation. All manifestations which we have discussed in the form of reactivation of previous reaction, diffuse maculopapular rash, baboon syndrome, flexural eczema, vesicular or hand eczema, even vasculitis. So these are some of the examples. So in patients who were having previous sensitivity on for oral exposure to nickel, they developed flare-up of previous dermatitis at the site of contact of their spectacles, at the site of contact of garter belt, new onset vesicular eczema, vasculitic rash following oral exposure to nickel, dermatitis along their stent, and even baboon syndrome. Apart from direct contact to nickel, food materials which have nickel, like flaxseed, which is known to have both nickel and cobalt, can cause systemic contact dermatitis in these patients. Regarding other metals, gold is one which has shown to cause flare-up of previous patch test and dermatitis, and even toxic derma-like rash and transient fever. Chromium and cobalt have shown similar reaction. In mercury, even after mercury dental amalgam, nummular lichenoid dermatitis and other form of systemic contact dermatitis have been shown to develop. Regarding copper, there was a recent report where after a copper containing intrauterine device in a female who had previous sensitivity to contact, dermatitis developed. Her patch test was positive to copper and her dermatitis improved after removal of this device. Regarding medicaments, as we discussed, antibacterial and anti-inflammatory is the commonest group. This is a patient which we saw in our clinic who presented with these erythematous eroded plaque in the groin, in the gluteal area associated with periorbital erythema and edema. We initially thought of toxic epidermal necrolysis, staphylococcal scalded skin syndrome, but on detailed history, we found that patient was using topical terbinafine for his tinea cruris, and the reaction started after consumption of oral terbinafine as prescribed by local practitioner. His patch test was positive, and then we treated him with tapering doses of oral steroid. Similar reaction have also been reported even after antiviral and also antihistamines. So this is an example of baboon syndrome developing after consumption of hydroxyzine, which is an antihistamine. In the food materials, so as we discussed, various foods like bean, lentils containing nickel, potato containing chromate, flaxseed containing cobalt, and various other foods material containing balsam of Peru may cause various type of systemic contact dermatitis, ranging from vesicular hand dermatitis to flare up of previous dermatitis and even erythroderma. This was a review conducted recently where they reviewed all the patients who has developed systemic contact dermatitis following oral intake of balsam of Peru. They enlisted all the food materials which were suspected, and they showed that patients have developed erythematous maculopapular rash, erythema multiforme, even erythroderma after consumption of these food material. Regarding other contact allergens, even Parthenium dermatitis, there is a debate whether this is a systemic contact dermatitis or an airborne contact dermatitis. And we can see that there were attempts for oral hyposensitization in these patients, though the results were not very useful. In the diagnosis of systemic contact dermatitis, history is of paramount importance, as is with other patients of allergic contact dermatitis. So there should be a history of recent intake or recent exposure to an allergen and a prior exposure to the same allergen. We can also perform patch testing, oral challenge, and elimination studies can be performed if required. Regarding patch testing, we have commercially available drug kits for most of the drugs. For others, if they are pure drug, 10% solution can be prepared in petrolatum, and if they are tablets, 30% solutions can be prepared in white petrolatum or in water. There is some discrepancy in the recommendation given by European Society of Contact Dermatitis versus European Network on Drug Allergy. We usually follow the guidelines by European Society of Contact Dermatitis, which recommend a gap of 6 weeks to 6 months between the resolution of dermatitis and patch testing. Oral exposure or oral challenge is a useful method. It has shown a high sensitivity where precipitation of dermatitis was seen in 10 out of 12 patients. Though then various studies have shown that this precipitation one depends on the dose of the nickel given on oral challenge. So a high dose shows a higher sensitivity while a low dose shows a lower sensitivity. Similarly, it also depends on the intensity of previous patch test positivity and intensity of previous dermatitis. So +3 positive patch tests in the past showed a higher flare-up reaction, and intense dermatitis in the past showed a higher flare-up reaction. Regarding the treatment, if the reaction is mild, it can be treated with oral antihistamines and topical steroid. If it is a severe reaction, brief course of systemic corticosteroid therapy, as we tried in our patient, can be given. Some studies have also used other steroid-sparing immunosuppressive agent, and even PUA therapy has been used in few studies. Regarding nickel sensitivity, disulfiram, which is a nickel chelator, along with low nickel diet, was used for the management of hand eczema and had shown good efficacy, but disulfiram is associated with various adverse effects, so not used very commonly. Similarly, with low nickel diet, there are own problem. There are some studies which have given some guidelines for the low nickel diet. Some of them are that nickel plated utensils should not be used and should be replaced. Similarly, acidic food should not be cooked in the stainless steel because it may result in dissociation of nickel. So these tricks can be used in these patients who are showing a sensitivity to nickel. Regarding other metals, also similar guidelines have been proposed: low chromium, low cobalt diet. But are these diet effective? So there was a systemic review conducted for balsam related systemic contact dermatitis, and it was shown that 47% of these patients showed good improvement with dietary modification. So some dietary modification, if possible, can be recommended. American Contact Alternative Group article, they have given food avoidance diet. So this article can be referred if we come across such patients. Similarly, similar group has given a low nickel diet scoring system. So they have given tables of various food material and relative scores. So we can use if we come across such patients. So in conclusion, systemic contact dermatitis, as we discussed, it is a cutaneous eruption in response to systemic exposure to an allergen in an individual who has a prior sensitization. The exact pathomechanism remain unclear. Should be considered if we see a patient who has a widespread or there is a recurrent dermatitis or it is treatment resistant, we should suspect of systemic contact dermatitis. Patch tests remain the gold standard for the diagnosis. The main stay of the treatment, as is with other type of allergic contact dermatitis, will be avoidance of that particular allergen if possible. Diet modification can be done, though further studies are required to clarify the underlying pathology, pathophysiology, and to evaluate the efficacy of these food avoidance diets. Thank you.
Thank you, Dr. Neetu, for the wonderful talk. So really, it is an excellent one.
Thank you very much.
So now I would like to invite our next speaker, Dr. S.B. Kavita. Kavita is an associate professor in Department of Dermatology, Gandhi Medical College, Hyderabad, and she is also currently treasurer in 2000 body TSIADVL, and she is very active and young dermatologist having around many years of teaching experience. And I invite Dr. Kavita to speak on non-eczematous contact dermatitis. Dr. Kavita, please unmute.
Yeah, able to hear me?
Yes.
Yeah. A very warm good evening to one and all. Today, I'm going to talk on a different topic, non-eczematous contact dermatitis. So, till now, we have been seeing various eczematous disorders where the diagnosis would be a bit easy. But this is one entity where we need to have a suspicion. Like, in case various dermatological disorders, whenever we are investigating, like we should always keep in mind about this non-eczematous contact dermatitis, which can mimic lichen planus to mycosis fungoides. So, allergic contact dermatitis, it is a common cutaneous eczematous disorder which is caused by contact with a range of environmental substances. Clinics of ACD are generally polymorphic. Besides the classic eczematous form, different non-eczematous clinical variants are possible. So the various types of non-eczematous contact eruptions could be, it can range from erythema multiforme like contact dermatitis, lichen planus like contact dermatitis, pigmented contact dermatitis, purpuric contact dermatitis, bullous, contact urticaria, chemical leukoderma, granulomatous contact dermatitis. These are most common. The rare entities which can also be encountered could be pustular contact dermatitis, papular and nodular contact dermatitis, sclerodermatous like contact dermatitis, lymphomatoid contact, vascular occlusive contact dermatitis. So, what is the cornerstone for this diagnosis? So, as we have been discussing, allergic patch test is usually it can give us a clue. If it is positive, it will show like eczematous contact, vesicular site of eruptions would be seen in case if the patch test result is positive. First and foremost, of all the non-eczematous clinical variants, erythema multiforme like contact dermatitis is the most common entity. So the most common things which can cause this could be like Brazilian rosewood, other medicaments like balsam of Peru, and the other miscellaneous products, chemicals like epoxy resin and formaldehyde contact. In contact with this, it can result in the formation of this EMF-like lesions. So, early lesions are usually eczematous in morphology and localized at the allergen contact site. After 1 to 15 days delay, the EMF-like eruption follows, involving the area around the original lesions or rather extending to the whole cutaneous surface. Target like erythematosvesicular or urticarial lesions are usually characteristic feature, and the resolution is a very slow paced. Manifestations persist usually much longer than the original eczematous lesions. Itching sensation is also typically present in polymorphic reactions. So patch tests generally elicit an eczematous positive reactions with this. Purpuric contact dermatitis. This is an unusual observation and is usually seen in the people who are wearing shoes, mostly rubber ingredient, which usually consists of this paraphenyl diamine dyes. So the eruption evolves in several weeks after the withdrawal of the offending agent and resolves with more or less persistent pigmentation. The purpuric aspects of this contact dermatitis and the respective patch test reactions can be secondary to irritant and are more frequently allergic mechanisms. So the most common, as I've said, the optical whiteness or azo dyes, rubber compounds, and fiberglass. These are all the things which can induce this purpuric contact dermatitis. It can be either irritant or allergic in nature. So from a clinical morphological perspective, differential diagnosis is not straightforward. Both present with palpable purpuric elements, evolve slowly, and are followed by variably intense and persistent pigmentation. At times, clinical extension represents a useful feature in differentiating these two forms, the irritant being strictly limited to the contact sites. Moreover, lesional elements resolve more rapidly and are less infiltrated in the irritant form compared to the allergic one. The allergic form of this purpuric contact dermatitis generally features diffuse and polymorphic manifestations. Papillopurpuric and papillovesicular lesions parallel classic eczematic foci. So the latter are usually limited to the original contact site with the offending noxa. Lichenoid contact dermatitis. It is an uncommon form of non-eczematous contact dermatitis, usually the presence with the clinical features resembling those of the lichen planus. It can affect both skin and mucous membranes too. Here, mostly the causes, the color developers like paraphenylene diamine substances derived from that are the most common cause of allergic contact lichenoid eruption. Nickel, aminoglycoside antibiotics, and methacrylic acid esters for industrial use have also been described. In case if there is any dental restorations, they can also involve the oral mucosa too. So clinical, if you look up into the clinical features, eczematous lesions usually evolve or associate with papillous lesions with peculiar lilac red gradation. The eruption mostly involves the contact sites, later widely spreading with mucosal sparing. Course is prolonged and leaves variably intense pigmentary changes lasting up to some months. So lichenoid contact dermatitis has to be differentiated from the lichen planus with its characteristic papillous polygonal lilac lesions. The onset of this lichenoid contact dermatitis is almost invariably acute and the eruption spreads rapidly in contrast with lichen planus, which takes a long duration. Frankly, eczematous lesions at the primitive site are not noticeable in many cases. So if you look up into the histopathology, lichenoid contact dermatitis, usually the spongios is the most common feature of this. And if if you find any basal cell vacuolar degeneration with pigment incontinence, then it can suggest you of lichen planus actually. So lymphomatoid contact dermatitis, this is an uncommon dermatitis, manifests with the clinical features of plaque parapsoriasis or an early stage of mycosis fungoides. So there are no specific causing haptens, the most frequently reported being paraphenylene diamine, resin, gold, ethylene diamine, and nickel. So lymphomatoid contact dermatitis and mycosis fungoides are likely present with infiltrative patches. But in case if the histopathology is, if you look into this, the prominent mycosis fungoides cells are usually absent in this lymphomatoid contact dermatitis. So the histopathological features, usually lymphomatoid contact dermatitis, the spongios is the most prominent feature with perivascular lymphocytic infiltrate, whereas in MF, you can see the atypical lymphoid cells with band type infiltrate. In pigmented contact dermatitis, it can also be prompted by azodice. Hyperpigmentation was noticeable usually in dark skinned individuals, while fair skinned ones showed the signs of classical eczema. So mostly the Sudan burn, brilliant lake red, they are the offending colorants which have been reported. Real melanosis is nowadays also considered as a pigmented contact dermatitis, mostly from cosmetic sensitizing fragrances and chemicals. So these are the various causative
Kavita, you've gone mute.
Able to hear me, ma'am? Hello?
Yes, Kavita, carry on.
Yeah, pustular contact dermatitis. It's one of the rare variety of non-eczematous. Pustules are usually associated with irritant reactions. Nevertheless, allergic pustular reactions are known from nitrofurazone, black rubber, and minoxidil. The other dyshydrosiform contact dermatitis. It can be primary or secondary. The secondary dyshydrosiform contact dermatitis, it is defined as a contact sensitivity, which complicates a pre-existing primitive palmoplantar formifolix, which tends to a chronic recurrent course, constituting a predisposing factor to occupational and extra-occupational contact allergy. Topical medicaments and paraphenylene diamine, chrome, cobalt, nickel, and phenol, formaldehyde, they are most common implicated haptens. So if you look up into the differential diagnosis, if you look up this DDs, so the main features of this dyshydrosiform ACD, mostly the palms and soles are involved in both the cases, formifolix and dyshydrosiform, but dorsum of the hands are usually involved in dyshydrosiform ACD. Whereas the vesicles are usually very tiny or minute in this formifolix, we have a large form coalescing vesicles. So scleroderma-like eruptions, solvents have been reported as predisposing or eliciting factors in some patients. So the most common solvents will be aromatic hydrocarbons such as benzene, toluene, white spirit. and the aliphatic hydrocarbons. The associated scleroderma and morphia like sclerosis is usually limited to the skin of the hands and feet where there is direct contact has taken place. The clinical findings are usually indistinguishable from those of morphia. Histology usually shows dense sclerosis of the reticular dermis and subcutaneous fat and lymphocytic inflammatory infiltrate. But serious biopsies of the test site showed transition from the spongiotic eczema towards the features initially to inflammatory morphia like over a 5-month period. The granulomatous eruption, skin injury from zirconium, silica, magnesium, and beryllium may also cause granulomas. Some reactions are usually due to a delayed type of allergic reaction that can be confirmed by patch testing, while others are non-allergic reactions. Clinically, the granulomatous eruptions appear 4 to 6 weeks after applying the zirconium compounds and are usually confined to the area of application. The histology usually shows epithelioid cells and may be indistinguishable from sarcoidosis. So this is a granulomatous reaction usually encountered with tattoo pigments, and which can mimic sarcoidosis and lymphocytoma cutis. So always we should keep in mind whenever we are diagnosing non-eczematous conditions also as one of our DD. So this is another bullous contact dermatitis. It has been reported from cinnamon due to the contact with cinnamon and nickel causing these vesicles. And other variant is nodular and papillary eruption. This can be induced by the gold, which can sometimes last for months. A nodular eruption due to the dental amalgam, which can also mimic oral carcinoma. So this all have to be kept in mind. Erythema is an exfoliative eruption. Localized or generalized erythema with or without papillovesicular eruption followed by exfoliation may be due to a toxic or allergic reaction from percutaneous or mucosal absorption of these chemicals. So this reaction may persist for weeks as such. So this has been discussed by Dr. Josna. So before I conclude, I would like to say the reason for this underlying non-eczematous clinical polymorphism, they lie in the different noxia and the clinical modalities, and also the individual susceptibility and the various targeted cutaneous structures. So these clinical entities must always be differentiated from the corresponding pure dermatitis, which are not associated with this contact with exogenous agents. So always the clinician should have an idea whenever we are going to deal with this. So always non-eczematous contact dermatitis should be kept in mind before subjecting the patient for unnecessary investigations in case if you are suspecting. Thank you all.
Thank you, Dr. Kavita, for the wonderful talk. So there are different types of non-eczematous allergic contact dermatitis are there. So now we will move on to our next interesting program, that is panel discussion. Moderator is Dr. Pavitra Vani Patale, madam. Madam.
Yes.
So please.
I'm just screen sharing.
Yeah.
Would you like to introduce the panelists, Sudha?
Yes, madam. You please introduce, and Dr. Naeem Sadat sir and Dr. Anand is also joining us.
Do we have their...
I'll introduce, madam. So along with the speakers, we have Dr. Naeem Sadat sir. Dr. Naeem Sadat is professor and HOD Department of DVL, Deccan Medical College, Hyderabad. So he had many publications in national and international journals, and author and co-author for the chapters in 2 textbooks. And he was a guest speaker and panelist in various national and international conferences. Dr. Naeem.
Good evening, madam. Good evening, everyone.
Welcome to the panel discussion. And the next panelist is Anand, who is joining us, Dr. Anand. Dr. Anand is a well-known dermatologist He's a consultant dermatologist and hair transplant surgeon in Kim's Hospital, Hyderabad. And he had fellowships in ISHRS, American Board of Hair and Restoration Surgery. And he had been organized many workshops at Kim's. Under Anand, we have organized many workshops. Madam, please
Good
carry
evening,
on.
madam. Good evening, everyone.
Thank you, and welcome to my panelists. Thank you for accepting to be on this one. Should I screen share again?
Yes, ma'am. Yes, ma'am.
Yes. Okay. Okay. Basically, so we've been through this already. Basic introduction, common, according to me, quite underdiagnosed. Overlapping irritant allergic makes it more complicated, and patch testing done by very few. Actually, talking of patch testing, I think one good offshoot of corona is we have learned that we can probably follow up for the fifth and the third and the fifth day and seventh day. We can follow up online, so that has come as an advantage. So maybe more of us can take it because many people come from far off, and sometimes we won't be able to. Previously, I used to ask them to take photos. Uh, of course, when we remove and the first visit is compulsory because we have to do it the correct way. But then follow up, they can take pictures or we can see them on the phone nowadays. So that's one offshoot of COVID times. I was thinking. And of course, interpretation also is not easy. Many times we get false positives, and many times we might miss out on what actually has caused the problem. Um, I am not able to see all of you in, he told, okay. Right, so coming to the first case, this was sent to me by Dr. Anand. It's Dr. Indira's case. Dr. Indira is Associate Professor in Osmania Medical College, Hyderabad. So this patient came, she had gone to a native coastal area and then developed severe burning over eyelids where she had applied wet cloth continuously. Then she developed swelling and redness of the periorbital area and more rashes over the neck and back of the right leg. She gave history of peeling cashews from raw cashew nuts. So here the history was straightforward. The patch test was not done. We'll go over to Dr. Anand. What makes you think it could be the cashews causing it, and how common is it? You're muted, doctor. Please unmute yourself, Anand.
Yeah. Actually, this patient initially, when she had a symptom, she presented to me, and that time even I was unable to come to the conclusion. Just I prescribed the topical medication and antihistamine and sent her the way she was presented initially. But of late, this case was discussed in the TSIADVL academics groups. When Indira Madam posted this case in the academics groups, then I realized that. So even at the first time presentation, I didn't realize that it is a cashew nut dermatitis. So then Indira Madam, she's slowly discussing about the case. Then this presented like she was before developing, she peeling off the raw cashew nuts from in coastal area because that is very common in the coastal area. So that is how, because she peeled up the everything, the toxic oil and the nut shell will there na? So that is the most toxic allergen one. So she keep on touching on eyelids, and the toxic oil also sometimes irritant also in the eyelid. So she keeps on touching on the eyes. That is probably provoked the allergic contact dermatitis kind of picture. So initially, this case, I was I didn't thought of the case of like a cashew nut contact
How were
dermatitis.
her hands, doctor? How were the hands?
Yeah, she had in on the neck and thighs, and she had some eczematous dermatitis also.
On the hands also, did she have
Yes.
any?
Even that time I didn't. This photograph was taken by a madam only. So I requested her that we will discuss this case in this contact dermatitis. Then she said okay. She had given permission.
So have you looked up about cashew nut contact dermatitis? Any more inputs you can give regarding what causes and what type is it? Is it like purely allergic or is it a combination? What is it?
It seems to be purely allergic contact dermatitis only, madam. and allergic because these are the separating of the nuts from that cashew apple is a very difficult process because right now it is a mechanical only. So it's a difficult process because this cashew nut below that cashew fruit, the nut will be there. They have to separate that nut. So to separate from that nut is a process. Usually in the Vietnam, they have automated mechanics machines are there, but in India, especially in coastal area, there is no machines. They have to separate manually only. So during the separate that nutshell below that there is a toxic oil is there that contains the allergens.
Yes.
So that causes the allergic contact dermatitis because these basically these cashew nuts it contains one ANH01 type of it is a vicillin like protein, and ANH02 it is a legume like protein, and ANH03 it is a 2S albumin. These are the three major allergens which is present in the cashew nut.
Okay, so this shows that very often eyelid dermatitis can be the first presentation or very prominent presentation because if we touch the face now with COVID. Everybody has realized how frequently we touch our face and eyes, so that the transference can occur, and because the skin is thin, the development is earlier or quicker in that eyelid area. So I'm going to give some more eyelid dermatitis pictures and what all they could mean. Actually, when we go to the next one, this one is my patient during the lockdown. Saw her online. Um, so she was a 7-month lactating woman with itchy rashes of 3 months duration. She was given various oral steroid courses, calamine lotion, moisturizers, and steroid antibiotic creams. On that time, she had papular rashes on the arms and forearms and urticarial rashes on the cheeks and hands. Total count was high with eosinophilia and IgE also elevated, though she did not give any family histopathology. So these are the clinical pictures. She had rashes like this. You can see that ranging from erythematous patches to mild urtication to papulovesicular. So first I treated her with antihistamines. She kept coming back repeatedly. And one fine day, I got the history that they were using this marking nut. That is I think most of you are aware of this, that they use it as a antiseptic. The fumes are used as a ward of evil. Various things are there. Though I was reading up about marking nut, and it is considered to be highly in Ayurvedic medicine, very many applications are there. But we do see this, and I think you all got to see. Any comments on your experience? Marking that, because whenever it's like latex, it can cause urtication, it can cause systemic symptoms also. And anything you want to add?
Madam, I have seen many of different varied manifestations of these cases, particularly when I was doing my DNB in Deccan Medical College. There I have seen people using this liquid for different indications, for cracked legs, for dandruff, and multiple uses. So, but particularly now, whenever any lactating mother with this vesicular eruption, first doubt goes in favor of this. Marking nut allergic dermatitis. When a patient is directly using herself, it can be manifested on the hands. But when someone else is just using the vapors to ward off the evil, it manifests particularly on the face.
Yes, and at the same time, I had a male patient also presenting. Eventually, it turned out they were doing the same thing, and not only he, other people were affected in the family. So I think there is an element of both allergic as well as irritant aspects to it. And the interesting part, why I put it here, is they all belong to one family called Anacardiaceae, I think, called the cashew and this one. So I put it after that. So the cashew nut allergy, according to the books, is very high in certain areas. Even in the US, they've reported as very high incidence. But here, this is where I was telling about knowing our customs, because it took so long for me to log on to it. But people who see a lot of patients, I think in academic discussions, we very often see this marking nut being mentioned and cases being seen. Dr. Naeem, do you want to say anything
Yes,
about
madam. It's quite common in the old city part of Hyderabad.
Yes.
as Dr. Josna was mentioning, mainly to ward off the evil.
Alopecia areata, same one, marking nut only they use, right? Or is it?
Yeah, for that also,
So
yes.
that is Nepali seed, madam. That is different.
Then even they use this also, madam.
Marking nut also?
They use this also, yes.
Yes.
Madam, and cashew nut allergy is co-sensitization has been seen with pistachio. It
Yes,
is
pistachio.
the
And
most common. I think also belongs to Anacardiaceae family also. And apart from that, hazelnut and mustard seeds, peanut. Peanut is reported, but cross-sensitive. Sometimes mangoes also.
yes, I was going
Mangoes
to
also
mango is a
Anacardiaceae
common
family.
one, and we see
Yeah.
the GD mango
Yes.
use the same
Sesame,
GD for that also.
soybean, walnut, almond,
Unripe mango.
orange seeds, all these are co-sensitization with the cashew nut allergy. Ma'am.
Yes, they are same family.
Yeah.
One interesting case, madam, like once a patient with similar reactions, but basically all of them were teenagers having similar vesicular eruptions only on the forearms. So when after taking history repeatedly, I could trace it out like they had used this marking nut 3-4 days back, and they have a pet dog. So the pet dog hairs have been like infiltrated with this dog, and whenever they were holding the dog, they were developing rash multiple days with similar areas, and all of their friends, all the friends had similar rashes.
The group is Erosiols, I think, and they're supposed to be very strong allergens.
Yeah.
Okay, go to the next. Continuing with eyelid. So eyelid dermatitis, you can see here swelling. This is unilateral here, just edema of the eyelid. And if he presents to you like this, and if you don't look any further, then you can miss. He has this dye allergy. So he had this acute dye allergy. You can see there's some amount of acetylation oozing there, but he had this as a prominent feature, the one-sided eyelid edema. What else would you think of in somebody presenting like this? Of course, this is very straightforward, but you can see there's a very bright erythema here in the scalp also. Any inputs on this one? Then we'll continue regarding eyelid dermatitis. This was a patient who came to me some years ago, and she gave 5-day history of rash around the eyes and 2-day history of rash around the mouth, and she had some rashes on the neck also. You can see edema and this inflammation, suggestive of an eczematous type of reaction only. So when we took history, now what are the possibilities here? She actually was given Dexacort N ointment. For what reason, I can't remember now. This is an old patient. And was treated with Fusidin H cream. So after treatment, it actually aggravated. And when I went back in the history, she had come long back, almost 3 years prior to that, with this acute reaction. That time also she was given the same cream, probably not H. So what do you think in this case? What are the possibilities?
So the name indicates probably it was neomycin content.
Yes.
Dexacortian. So along with that, there are of course so many eye drops, antiseptic eye drops, antibiotic eye drops, which can also cause.
Where is Kavita?
Yeah, ma'am. Yeah.
Okay.
Kavita is there, madam. Dr. Malati is also there.
Yeah, I can't see them. That's why I'm asking Dr. Malati.
Dr. Malati is there. So one small announcement. We request all the audience to post their queries also. Madam will take up at the end.
Why am I not able to see them? I'm not able to see them. Dr. Malati, please give your input, sir, because I'm not able to see you. I'm not. He said everything will go. Yeah. Still, I can't see her.
Fusidin is fusidic
yeah.
acid is one agent which is known to cause sensitization. Especially if we give the steroid fusidic acid combination for many of these venous eczemas or infected eczemas. But this results in sensitization in these patients present with worsening of their eczema, and they present with contact dermatitis later. So it's always preferable to avoid neomycin, bacitracin, tramycetin, fusidin containing combinations. Mupirocin is a safer combination with steroids if we want to give.
Also, because it's ointment based, I was just looking up to see what Fusidin H contained, and its preservative is called polysorbate. I'll come to that again. Polysorbate or sorbic acid. It's a very common preservative, and that also is an allergen. So, what exactly causes in this, we don't know. But when you are, that's what the purpose of bringing it is here. When you are prescribing to treat a known allergy, it's better to avoid anything which contains allergens again. So,
Malti madam, can we have cross reaction between neomycin and fusidine? Is it possible or like?
It is reported a lot of these topical agents also have cross reactivity. So,
but the group is different. I'm not sure about that. If it's gentamicin, yes, definitely, because the same group.
neomycin causes, ma'am.
But I don't know.
Not with fusidine.
I would go for in these cases, my suggestion is, and that's what I do, is to prefer antibiotics. Check that they don't contain any preservatives. If you're going to give a steroid, topical steroid, give a ointment base, and very often they respond very well. So this is another eyelid dermatitis. She was staff in Yashoda, very mild looking eyelid dermatitis. But if you again look, this is what she had around the years. Young patient, but still I think she was doing some hairstyling with dyes. So some sites to look at if they're present only with eyelid dermatitis. What else? Where else would you look for? Suppose, can you suspect, say for example, nail varnish dermatitis in this patient?
Possible, ma'am. Eyelid dermatitis, most common cause is nail polish dermatitis, and she's a staff, hospital staff also. A lot of things which she handles, topical medicines and all, gloves, latex, and many things which she handles, which she's allergic to, and I being thin skin, more prone for contact dermatitis.
Yeah, but I would think that if it is carried from the hand nails, fingernails, nail varnish, you would expect some amount of asymmetry. So that will be a clue, according to me.
On the dominant side, it will be more because of eye rubbing. That's one thing. But here it is quite bilaterally symmetrical, as well as we can see some involvement of the retroauricular area. Probably there is a little bit sparing just under the ears on the extreme right photograph. Indicative of photo sparing, because it's not looking like the Wilkinson triangle as such.
No.
It can probably be something other than the nail varnish also, madam, because it's looking.
In this patient, it is dye, because she had that.
Dye. Okay.
In this patient, it is. So I was asking, how will you think of a nail varnish? Probably if it is asymmetrical.
Only eye. Then you can. Yeah.
So two more eyelid. The left one, obvious, very obvious. What would you think of in this?
Airborne.
Phytophoto or
Airborne contact dermatitis.
Yes, airborne contact. But again, we know that Parthenum and things like that can have a combination of photo and airborne. So even apart from the, I didn't take the triangle there. It might show, but he had some amount of photo element also, especially on his forearms and upper trunk. But classic, the whole involvement is there, and very common in this will be Parthenum. This man, he came with this sort of edema again. I don't know, I can't remember the history. I just found them in my pictures. And what would you give him at this point of time as treatment? What would you like to give him?
Systemic steroids preferable, ma'am.
Sorry?
Short course of systemic steroids.
Just a 4-day I gave, and this was what he had. There you can see now, it is basically an eczematous reaction only. Maybe the inkling could be because of reduction of edema. But when you see here, you won't think of eczema as such. Probably originally it was an eczematous reaction. So here, I don't know the reason. He hasn't dyed his hair in recent times. Maybe some application. Very commonly, eye drops cause this kind of thing, but it will be more in the lower eyelid. And of course, when they rub or try to treat, the whole thing might spread. These two opinions on this.
Lichenoid eruptions.
This is this chest area, and this is just about this is the trouser.
Any use?
Slightly, ma'am. Metal allergy. Usually, these children wear those sacred threads, and that contains amulets and metal dollars and all those things. And this is close to the
buckle.
Yes.
Belt or
and even jeans pants buttons.
Buttons.
That comes in direct contact with the skin in that area if they're not wearing inner garments.
So many times the umbilicus and periumbilicus, just below the umbilicus, it becomes very difficult, especially if they have tinea, whether there is additional, if they're not responding to antifungals, they have other antifungal and other fungal lesions, this can persist. And then you should suspect maybe there is additional nickel allergy. Here, this boy used to have put his keys in a chain. This man or boy, I don't know. So this again is nickel. And in women, we very often see they have pins, safety pins in their chains. And you see a rash just in this area, you should suspect nickel allergy. Here and where the pin is. So that points to a nickel dermatitis possibly. The other thing which can be is, okay, this is a case of vesicular type of reaction. You can see even on the forearms. I think Jyotsna mentioned it. And this is to PPD, the hair dye reaction. This is how her face was. She had very severe reaction. And you can almost think it is pemphigus. If you just look at her, you can suspect pemphigus if you don't get the history of it. Anything else you would suggest we think of in her? So sometimes it's caught unawares, yeah?
We should look into the demarcation, madam, the exposed and unexposed part. That will be a dead giveaway for detection.
Yeah, there's a problem with hair dyes, especially people don't use the careful the way you use it. I have had patients present only with vesicular ulcerated lesions on the face and on the hands because of the spillover of the dye. Because the scalp, there is some protection, no, it doesn't touch. So you can get ectopic lesions elsewhere, and you have to suspect it and look at the take history and look at the scalp as well. Yes, this is very extensive, probably secondarily infected also, but very severe reaction. Here is another one. So this rash is there, itchy, very peculiar, urticated sort of rash, and that's what he was wearing. And here there is a lichenoid rash, and if you see carefully, there is a red thread here. So colorants were being mentioned. In this, there could be multiple reasons. There is color of the bead, there is metal in this, and there are coins which are metals. So any number of reasons, it's easier to tell him not to wear anything. But if suppose he presented only like this and didn't have that, then we should, again, distribution-wise, suspect that it might be possible.
One more thing in such patients, madam, these devotees, they take bath very frequently and they don't even mop it dry. They leave it wet for quite some time. That may also contribute to like precipitation of contact dermatitis in such patients.
Even skin dryness increases because the happens to be dry season, repeated bathing and all. So
That other aspect is, suppose you're having this and it's a hot atmosphere, there'll be leaching because of sweating also. So along this thing, that must be another reason also. And here there is slightly lichenoid. So colors and can cause lichenoid dermatitis. Is lichenoid more than eczematous there. Coming to foot dermatitis, I just put up 3 or 4 types of foot dermatitis here. So this is a classic subacute eczematous type. This is chronic eczematous type, but all of them are having that shape of this one. And this is the papillonodular. So it went into the chronic stage, and you can see post-steroid hypopigmentation in between. So this I put here. But foot dermatitis also involves the sole. So insoles, we have to think of what insoles they are using. Very, very difficult to get substitutes for foot dermatitis. This I'm just putting it here. Dr. Swapna gave me this. She did her thesis. She's from Khammam, Mamata Medical College, and she had done 35 cases, maximum potassium bichromate, and then next was MBT, which is they are rubber chemicals. Potassium dichromate is leather mostly, and nickel and cobalt. These were the maximum reactions. And out of 22 shoe dermatitis, 13 had positive, were positive. So this is foot dermatitis, and this specifically shoe dermatitis. And 23 of the positives had multiple. 23 patients had more than one positivity. It's just to show that how it helps if you do patch testing to select the material which they could use. So, any experiences you want to share with this, Dr. Malti?
We have done recently a study on patch testing in children with foot eczema. So many of the cases which we tend to think as juvenile plantar dermatosis and atopic feet eczema in children, the whole idea of study was to do patch testing in all children irrespective of our clinical diagnosis. And we found that a significant number of which we just ignore of as JPD or as atopic eczema were also positive. And nowadays kids wear a lot of these colored shoes. Most of the things were dispersed dye positive, orange color dye positive, blue color positive, because all their shoes were of those colors. And kids were wearing socks. They also had a high risk of foot eczema. We always tend to forget the socks that they wear, especially the dark blue ones, the navy blue ones they wear, and because of sweating, that predisposes to eczema. Another thing, the fancy slippers which they wear has a lot of all these decorative items, and they have glue allergy also. So these were all common. And when we deal with foot eczema, apart from footwear, we should also think of other things like children's walk barefoot. So they get exposed to parthenium by walking over the parthenium. So that is one thing which we need to consider. And the cement flooring and the red oxide flooring which people have in their house, the feet is wet and they can have contact damage. Sensitization to cement and all those things also needs to be considered. So children, we should always consider patch testing when they present with foot eczema.
Nowadays, it's an indication. Plantar dermatosis, comma plantar, especially plantar, or foot dermatitis in children is an indication for patch testing.
Madam, I agree with Dr. Malti, madam. Similarly, we had done one study of one of our PG had done 1 year ago, and the findings were somewhat similar to this only, like potassium dichromate and even the some amount of paraben allergy also was seen. Like paraben allergy, we can attribute to medication, those kind of things, and also socks. Among the contributory factors, socks also was found to be one reason, especially the low cost socks, which have high amount of bleaching of the dyes. They can cause this kind of allergy. And also we should look into some other contactants like detergents, like which can cause cumulative irritant dermatitis under the occlusive action of the footwear. Other than the contact dermatitis itself, allergic contact dermatitis, cumulative irritant dermatitis is another thing which we have.
So that kind of thing will tend to affect more the dorsal compared to soles. Yes.
Yeah, awesome.
What would you advise? You're not able to do patch test. You have all this information. What advice would you give a child or somebody with foot dermatitis?
We do perform patch test, madam. Like wherever it is not possible to perform patch test, obviously we should advise for avoidance of like any accumulation of detergent or dust, cement particles, those kind of things. As well as change of footwear, we can just give a trial. If a facility of patch testing is not available, then one can definitely try different material of footwear to be tried.
So what material would you advise? Like it's very difficult to get materials. For example, I tell them.
For example, if it is due to leather, as we are suspecting leather chemicals, potassium dichromate, which is used for tanning of the leathers, one can go for alternative materials like plastic or canvas kind of things, some jute kind of footwear.
Yes, that's what I advise generally.
Alternative methods.
Either jute cloth or canvas. But the problem, one thing is finding them is very difficult and a little impractical because when they get wet, it's a problem. They should always have a plastic sole to them. But problem is that suppose they are allergic to dye, the adhesives, which is one other thing, they will contain adhesives also. But overall, if you don't have a choice, can't do patch testing, then the advice will be to go for that and cotton light colored socks or non-dyed socks will be better or light colors at the most.
Yes, regarding the color, there's one important point, madam. Like the darker color clothes, whether it is socks or any other clothes, they contain the dispersed blue and those kind of dyes more. Lighter clothes will not have much of dyes.
Okay, this going on to foot dermatitis is another foot. There's leukoderma, you can see. And this patient is Dr. Pratyusha. So we had discussed in the last meeting. He had positive, he had positive to epoxy resin. This is what we're talking about. The resin is used for as a binder mostly. I don't know if it's present in anything else. Dr. Malti, do you know epoxy resin in any material apart from as a glue?
As mostly glue only, ma'am. Colophony and epoxy resins, mostly they come together.
He says rubber slippers. That is part of the rubber as well. I'm not sure. So this is one area, it's called chemical leukoderma, where anybody can contribute. It can be post-inflammatory, like here, PPD. I think Dr. Kanta showed one case, just now. So it could be post-inflammatory or direct melanocyte death due to the chemicals, or sometimes combination of both. Here you can see the PPD positive. Any contribution from this one? How about treatment? So here are some more chemical leukoderma cases. This is my patient, and here. So this spectacle is the plastic. We were reading up last time because of this, and plastic has especially soft plastic, which comes in contact here with those rests here. And behind ears, in the recent times, many children are using, youngsters are using those soft hearing caps. They have developed a lot of chemical leukoderma. So, yeah.
Most of these chemical leukodermas, once the offending agent is removed, they usually respond, madam. Again, they may repigment. In case if the candidate is suffering with genetic predisposition of vitiligo or something, there we can actually advise them with topical steroids, depending upon the area of involvement.
These people generally don't respond easily. That's my experience, and that's also what the book says. We don't know the reason. Invariably, they have some surgical procedure.
I usually recommend tacrolimus, topical tacrolimus, and if still the response is slow, I give a short course of narrowband UVB to repigment that area.
Yes, but how is your response? How is your experience?
With narrowband UVB and eczema, they are responding.
Okay, that's a good thing because I didn't try that.
Topical tacrolimus. If they're still not responding, I wait for 1 month, and if they're still not improving, then I go with this. Additionally.
Any experience, similar experience? And this is.
I also agree with it, madam.
They respond to phototherapy.
Yeah. No, they respond. Okay, so next time I should try that. The books didn't say that, but never mind. This is again pocket they keep, no wallet, leather wallet reaction to that. Continuing on this is binti dermatitis ending up in leukoderma. And this case is mine, but actually the Pratyusha's case, she had a positive reaction to butyl phenol and butyl alcohol. This is part of the cosmetic series, but she selected specifically for her and found that this has caused it. So para group of same related to paraphenylene diamine, PPD is paraphenylene diamine. These are also para medicines, chemicals. So they tend to have the same effects. Another eyelid dermatitis, mild eyelid, that is bindi and finger. And this lady was positive to a little bit of parthenium, that could be coincidental, or cross reaction to composite, I don't know. But she also had reaction to haldi and kumkum. Continuing on that, this was another lady who had reaction to kumkum, both here, single where they keep and here. And this has recovered after treatment. Then she came back again with some more reaction. Probably when we did a patch test, this was long back. 390 is part of cosmetic series again. It's not in the standard series. And I was telling you, polysorbate or sorbic acid is a preservative and I found it in preservative. But it also is content of many food items. It's a preservative for foods as well. Uh, juices and ice creams and things like that. So it could be one reason for systemic leukoderma, to keep it in, systemic contact dermatitis, you can keep it in mind. And so when you're selecting treatment for these patients, as I said, you go back again to using ointments if possible instead of and check for any preservatives or give an alternative. Okay, patches on hands, axilla, mild itchy in some areas. Diagnosis. Same patient. So she was using dye, but these were the areas involved. And so she got a positive reaction to all this, but strongest was her fragrance mix.
It can be even a moisturizer with any fragrance or anything else.
Deodorants using, madam?
Sorry?
Deodorants.
Yeah.
Deodorant.
But at that age, was she really using any fragrances or deodorants, madam?
Fragrances, that's the biggest issue with fragrances. They're ubiquitous, they're there in everything.
Madam, it can be even a general plain moisturizer with a fragrance mix also. Because on the face, usually we don't use fragrances as such, but
She seems to have applied, of course, the hair dye is there, PPD is positive, and hair dye application is seen in the photograph.
pattern, is
About
generally
the axillary area and the other area.
that generally. But axillary area, PPD, and you were mentioning dyes, no? So close dyes, because this is an area where cloth, blouse, sleeve rubs. So that one area. And this is an area where the patient, when we even sit normally, naturally, we put our hands like this. So this is the area which is exposed. So on the cloth, whatever. So it could be the dye, the clothing, all the clothing detergents contain dye, fragrances, and some of them some lighter dyes, but dyes are also present. So when distribution is there, that's why it's very important to look at the distribution, what that area is coming in contact with. Very often you see if there is nickel allergy, they may have where jerry touches the women, and in the waist with the cloth with jerry, that can cause sensitization, bangles, things like that. So here these areas I was just wanted to point out how some suppose you didn't have anywhere else and they present very often with this pigmentation in these areas, you can suspect a pigmented black contact dermatitis or post-inflammatory pigmentation due to contact dermatitis. Again, it can be only due to friction also, but you can see there is an eczematous process. It's not just thickening. So this is the paper which I give to patients when they turn positive, because it's very difficult to tell them, and then try to highlight what can happen. Even fragrance mix, there's a lot of course, everything is there. So perfumes, toothpaste, colognes, shaving lotions, even shaving creams will contain. So I ask them only to use a bland or just hot water to shave. And food items like sweets, ice creams, chewing gum, soft drinks, room freshener sprays. Airborne allergy also can be due to fragrances, agarbatti fumes, room freshener sprays, insect repellents, what you put, all those. So just wanted to show that. Any more you want to add to fragrances? I think now they're coming out with the second fragrance to mix. There is a consensus that we need to add a lot more things to our patch test, including tea tree oil and some of new preservatives. So somewhere here, Kali Mehendi, we all must have seen this. It is very difficult. Very often it leaves a very long-standing post-inflammatory pigmentation. The regular Mehendi doesn't seem to cause it. Mostly it is what the newer thing has come, no, Kali Mehendi. And I think it's the PPD in it. Black thread here, black beads here. So it's always a blanket statement. Sometimes we suspect, tell them just use light colored things. Another PPD, this patient has on the neck. Sometimes they can have airborne contact allergy picture as well, PPD. Okay, 67-year-old female, his hand and leg rashes, itchy, there's one patch here and here. And she's been using a hair dye for 15 years. She actually didn't complain now, but she does have an eyelid rash here also. What could one suspect? So she had a strong reaction to PPD and at 48 hours, but also to fragrance mix at 96 hours. That's low positivity to me. Ma'am, looking at these things, Dr. Malti, wanted to ask you one thing. Dark skinned people, redness is not seen that clearly. So I was thinking that they recommended palpating the palpation.
Palpating the lesion. They are telling that definitely allergic contact dermatitis will be indurated. So
Yes.
whenever the lesion seems to be indurated, then consider it as allergic contact dermatitis. And the side lighting, that is why the side lighting, ma'am. When the lighting is from the sideways and look at it from a distance, the erythema can be made out subtly.
Yes.
So,
Erythema can be made out, even the bulge can be made out, even without palpating. That is also. And the dermoscopy, is that being recommended?
no, ma'am.
So there's PPT, some cross reactions here, photocopying people can be exposed, oils and greases. So it's an accelerator in rubber. That patient there had was wearing rubber shoes, no? That could be PPT causing the leukoderma. It's also used in plastic industry. So it's efficacious, it's present in so many places. There is cross reaction parabens. So again, paraben containing creams, very careful when we prescribe to patients with contact dermatitis. PABA, we give a lot of PABA, sometimes even oral supplements. You can think of systemic contact here also. And I think erythema multiforme, like Kavita has mentioned, PPD chemicals, and airborne contact also. Right. 67-year-old retired army person came with spongiatic, pathologically proven spongiatic dermatitis. I couldn't find his photograph, so I put a similar one. He took a long time to respond, steroids and isotretinoin, and they were gradually tapered. You can see here the rashes were on the forehead, on the bald patch there, on the face, neck, arms, and also on the legs. And it was intensely excoriated the dermatitis. He came positive to not very strong positivity, and chlorocresol. This is another strong irritant, allergen. If it causes an allergy, it is responsible, then it can be severe. That's what I found. Any experiences with this chlorocresol? It is present in many of our creams. So again, I have patient like stasis dermatitis is not responding. It is just applying a cream containing chlorocresol as a preservative. That's just strong. So again, I'm saying even if we don't do all this test, take information from this, check out what we are prescribing, and avoid anything containing possible allergens. So ointment has a safe bet in that case because most ointments don't contain. Some ointments also contain. But, also petroleum jelly can cause, but in balance, you can prescribe something like that. So this is somewhat like what he had, but much more severe. This is a very quite erythematous. He had extensive lichenified lesions. 71-year-old male, again stasis dermatitis with generalization. He also took a long course of steroids and isotretinoin. Okay, so they come like that, Dr. Naeem, you wanted to discuss about management, systemic management. What would you prefer to give in this patient?
In a generalized condition like that, obviously we need to depend on the systemic corticosteroids as well, maybe a short duration. But only thing is, in the current COVID times, one should be careful not to give too high dose. We have to balance the disease activity and just try to give the sufficient enough dose and for shortest possible duration. That's the only thing I would like to point in this scenario. Whereas, of course, the avoidance of the allergen and other topical measures along with that.
What would you like to prescribe topically in this case?
Previous patient, madam?
In patients like this, like you are giving, you say short course of steroids, they usually don't respond because unless you think of possible contactants and give them very applications which are not going to aggravate it. So considering that you're not going doing patch tests, what applications would you advise these patients? Any of you can take it and contribute.
You're talking about the previous photograph you are talking about, madam, in that patient, or which one you are talking about?
A patient with the generalized eczema, be it crystallization, disseminated eczema, or extensive eczema, or contact dermatitis, what topicals would you give? Because if you're giving...
Madam, first of all, they should, their skin condition or moisturization of the skin is important. That's one thing.
Moisturization.
And along with that, of course, any mild to moderate corticosteroids, depending on the area of involvement and depending on appropriate to the age of the patient, that can always be used. But in a very generalized case, definitely there is a role for systemic corticosteroids.
Yeah, systemic, agreed. We have to use systemic It may not be, short duration may not be enough. They do take a long time unless you identify some possible.
That is for recurrences, madam. For the like immediate management of the patient, we can combine both topical and systemic corticosteroids along with moisturizers. And
No, question is, how would you select?
Prep therapy can be
you
given.
can select paraben-free and preservative-free
What were you saying?
available nowadays.
Prep therapy with steroids can be given, ma'am. We try that for a lot of our airborne contact dermatitis. If they are wet trap therapy, ma'am. Wet trap therapy, which we do for
Oh, okay. Yeah.
For acute oozy lesions, you are meaning to say.
Yes, sir. Because they may not require very high doses of steroids, and wet trap will also control the local inflammation, so the itching will also come down.
Yes, for oozy lesions, definitely yes.
And what
So,
would you apply?
Madam, what do you use for wet trap? Do you use normal saline?
yeah. Hello,
Yeah,
sir.
madam.
You're not
Asking, can't see.
For wet trap,
tap
what do
water.
you make?
Tap water.
Tap water. Okay.
Tap water.
Sometimes in the acute oozing lesions, then I use normal saline with gauge piece. I recommend to apply saline gauge piece like dapping for morning or 10 minutes, evening or 10 minutes. After that, advice to application of the topical moisturizers along with the systemic corticosteroids.
Yeah.
Topical corticosteroids.
Yes, 10, 15 to 20 of what we call saline suits.
Saline soothing.
Even
Saline
potassium
soap.
permanganate can also be used. And that
Yeah,
can
potassium permanganate also.
No, my question still is not answered. What topicals would you give apart from wet trap?
Madam?
And emollients, ma'am, like coconut oil can be given.
Yes. Yes.
Yeah.
So
Suppose it is a lichenified lesions, then I use
paraffin with
tacrolimus also.
no, the tacrolimus probably will cause irritation, and also some
No, it is not acute lesions, madam. It's a lichenified lesions.
because dissemination can be due to autosensitization due to infection. So a short antibiotic course also helps in them. As Dr. Malti was saying, coconut oil is a good thing, or liquid paraffin you can use on moist skin as moisturizers rather than formulations. Almost all formulations will contain either parabens or fragrances. There are some bland good ones. If you know your product, then you can use it.
Depends upon the stage, madam. If it is acute, means we'll just go with this warm saline soaks followed by the steroid application, or subacute and chronic, as you said, emollients and moisturizers.
The barrier repair is extremely important. So we have to have a known emollients, a group of them which we can use confidently in a possible contact dermatitis. So this is what we have to look at the contents, select some, use them regularly instead of experimenting, because this is, otherwise they will not settle down. That's what. Otherwise, and that's my experience anyway, which is much more than yours. Sorry. But because patch testing is not done that much, we have to rely on these methods. So here you can see the vesiculation starting, and though it's not the same patient, this type of thing will suggest autosensitization and spread. That patient was positive to formalin, benzocaine, black rubber, and disperse orange. Strangely, none of them were strong. Again, he was almost more than a year. He required steroids and azathioprine because he didn't follow instructions on not applying anything. Okay, this is another case. This patient came with this type of rash, and she was already on treatment for it. And this is a picture. What can one suspect?
Ear infection, madam.
No, this is a different patient. Sorry, this is one with arm rashes. She was a female with came with arm rashes. This is day 1. This is day 2.
What did she apply, madam, there?
She was only on topical creams. She was already on treatment, or I put her on cream. I can't remember. But why I put this here is this is one thing which should make you suspect sensitivity to the cream, especially steroid based, because the center will clear because of the steroid, but the rash will keep spreading peripherally because of the sensitivity. So when you see a rash like this was a very long time back, almost more than 10 years back. I just found it in my records. So this can happen, and you have to suspect possibility of steroid sensitivity. So the PISA is giving groups and all that. So again, whether it's possibly only steroid. Otherwise, still we cannot say whether it was a steroid or the.
If they are steroids, like if they are if the steroids are causing irritation, then even the center part will have that eczematous.
No, contact dermatitis is allergic contact dermatitis to steroid. The cream she's applying, and because of the steroid, the center is being suppressed, but the periphery doesn't have steroid. No, so the reaction is spreading. So eventually, this was just one day I discontinued, and already the erythema now started without anything else. It started coming down. After that, I lost touch, but I just thought it's interesting that, and it is described in the books. If you find a rash which is spreading peripherally, nowadays we'll think of tinea. There's another thing you should think of, that there may be steroid allergy. Any experience in this one? Anything else you want to add regarding steroid contact dermatitis?
The chlorocresol, the preservative you mentioned, that is also most common in steroid creams, madam. So chlorocresol allergy is also because of topical steroid cream, particularly betamethasone.
Yeah.
So this is whenever you are suspecting that thing, we need to check for the preservative.
Like some companies have parabens in all their creams. Some have the preservatives for antifungals, though, are mostly benzyl alcohol. Some of them have sorbitol, but benzyl alcohol is the commonest. And I have found sometimes antifungal creams causing. So even in dermatophytosis, if they don't respond, just withdraw the cream and see, that will help. This is a post-surgery medicament allergy, very clear. Just because both are topical related activity. Okay, I think coming to the end. This is a format I use, very easy to use. Do you use this something like this, Dr. Malti?
Yes, ma'am. Similar format only, ma'am.
And
At the end of it, we have one, like whatever comes positive, we just give the list of allergens mentioned in that report. It's like a report given to the patient.
this is interpretation. Here only we mention, and then there only we say whether it's significant or not in relation to the history and the distribution. Whether that particular reaction we think is significant, past relevance, present relevance. And in the actually, this is having footwear series. That's why it's extended. Otherwise, they'll be like what we think, what we suggest. And those papers which I showed you, whatever are positives, we give them that, and then ask them to keep them. Like
Also,
this.
the patients should be told about the products which are containing these agents to avoid those things. Like if we can give the list of that, that will be good. And in the
That's
Western
what we do
countries, they
it.
have registries.
Where they are present, and then take some history and tell them that, because if you give this huge list, then life becomes miserable. So you have to put a little more time and see where they might be.
Yes. You have to correlate with the history and occupation.
Temporal correlation.
Yes, and then ask them to probably stop those and see first. But very, very often, just going in for a very low maintenance life makes a lot of difference. Stop most unnecessary things and fine. So, any more addition? Anything we have? Any areas you want to cover? We missed. Want to put in some suggestions? So, how many of you are going to start a food patch test clinic?
We already have, madam.
Madam, anyone have experience in desensitization, madam?
Time or only PG's thesis they are doing?
No, madam. We have in the department. It's not only meant for PG dissertation. We
You have
regularly do it. We do it regularly.
Oh, then I should get a lot more information from you.
Yeah.
We used to do it, madam. Now we have actually got the Indian Standard Series now. So we are about to start in Gandhi.
Because
Malti madam, are there other chambers like the Sweden chambers, are they available for us apart from the King chambers?
We get only Finch chamber, ma'am. We should ask Cystopic to get it from chemodiagnostic. Like right now, even the skin marker pen, once we got. After that, they told it's not available. So we're not able to get this.
Because even the shape wise, they mentioned the square shape is more specific compared to the round shape. So that is a more specific value, and it has filter paper. So probably that makes us more easier to do the liquid
They
preparation.
can procure it for. They are the distributor here, no, ma'am. So if they can procure it for us.
why is it that nobody else is coming into that area? I don't know. No one else has picked up. Only Cystopic is doing for the last 20 years. So again, I think a lot of information if you can collect and on updating the series, because a lot of things are missed, I'm sure. Now instead of parabens, ethanol, that group is used, as preservatives. So they started developing allergies to that group now, but we don't have any means of testing it. So as I said, eventually keep getting information and then just use bland things as much as possible. Talking of coconut oil, I just wanted to share that even that the very famous parachute, they all have preservatives. So another thing you can advise the patients is to use virgin coconut oil or cold pressed coconut oil. That will take off that little bit of allergy. Because some people have reacted to the formulation.
Madam, how would you treat bindi dermatitis?
Mini dermatitis, initially with topical steroids and tacrolimus, and if they insist on putting, I ask them to put a small dot under, and or else somewhere else, which they almost never agree. In spite of husbands telling, and I'm all right, and I'm alive, so don't worry, but still, they will not.
Madam, one more thing is we can ask them to apply in the scalp in the parting line, because that area is relatively resistant to the contact dermatitis, having a thicker skin, as well as because of the increased number of sebaceous glands. The other thing is, like, I also use some products which are similar looking like kumkum. We get it from Geosmatic company from Pune.
I think, yeah.
Ketone, sir? Is it ketone?
Yeah.
Yeah, ketone. But for that also some people develop allergy. Very few people. We ask them to apply it behind the ear, test it for a few days, and then go ahead. Some people really like it. Some don't like it. They think artificial thing. It cannot replace kumkum. So as you said, like the
People don't use kumkum, mostly stickers. So the
stickers or kumkum, whatever, the ladies want to apply something at least. They don't want to stop that practice of applying something.
But what is ketone?
Something they, madam, sorry.
What is ketone?
That contains non-allergenic dyes, which looks exactly similar to kumkum color.
That also is application. Now, what I'm saying is
application only. It
is also application, madam. In few people it is effective, but few people again they are getting allergy to that.
Yes.
So some people
even hair dyes also, like non-allergenic hair dyes that we have.
Yes. Powder, liquid finger, anything, any kind of sticker. So patch testing them might help, and sometimes homemade, like there is a stone. No, originally kumkum is made by that, not a combination. Now it's all chemicals. It used to be from a stone. They used to grind the stone and get
limestone and
no, haldi and limestone is different. Also, you'll get red color. Haldi and chunna.
The original kumkum preparation, I believe it was based on that limestone preparation.
Limestone, is it? Okay. I knew there's some. So if you can get that, otherwise you have to ask them. I ask them, for sentiment's sake, apply as little as possible and a little farther away. Otherwise, that will never subside.
One advice I generally follow is applying in the parting line in the scalp. That also works in some people, not in everybody.
Because in North it's okay, South
they are okay with it. Yes, correct. Yeah. And even regarding the hair dyes that we have, botanical hair dyes, vegetable containing hair dyes, which are supposed to be non-chemical based, there also some people end up developing allergy.
Yes. Recently, this lipstick I come across, I was putting in our group also. You can beetroot juices and some vegetable juices. You can sterilize them and keep them in the fridge. Add a little bit of this thing, and that you can use for lipstick allergy. Of course, you can get a range of colors, including green if you want. And coming to hair dyes, I think we should discuss this. What do you advise for hair dyes?
Sir Naeem sir, like what I feel is like immediately after the reaction with hair dye, first 2 to 3 months I feel they're like reacted to most of the other hair dyes, even PPD free hair dyes also.
Yes.
But if we wait for some time, probably after 2 to 3 months, once the allergy subsides, they start tolerating the PPD free hair dyes. But in acute phase, immediately.
You're right, madam. But even then, after taking care of all these factors also, some people just do not tolerate. Even then. After taking care of all these factors.
Why testing is because I have had some patients who are allergic only to fragrance in the dye. All the dyes have fragrances also.
Yes.
In coming to hair applications, we should never forget to ask history of hair oils. All are herbal oils and some oils contain dye. For example, Vasmol when it was introduced. Such severe reactions people came with because it has dye in it added. And
few more questions if you can entertain. Anybody has experience with the true test, which is the ready-made thing? Maybe Dr. Malati madam can throw some light on that.
No, that's an expensive one.
No,
That's
not
coming from Denmark, no, doctor. It's very.
No.
Is it available in India, madam?
That's
No,
what
no.
I want to know from others. Has it
European
been
country.
used?
for nickel test is available. The one which we use for nickel allergy, that
Yeah.
we got. That also we got only once, sir. But I think that was as part of our contact dermatitis CME we had, and they had given us to test it out. But otherwise, we could not procure it regularly.
Available sometime back is almost 3 times, 3 times the cost of the one.
Yes,
Okay.
ma'am. It's costly, so they had given us to test it out. So that is how we had exposure to the nickel test. Otherwise, these ready testing things we do not available.
Talking about the true test, it used to be available some years back. I don't know, maybe because nobody encouraged.
I'm telling this 8 years back, ma'am, when we had the Corticon in Jipma that time.
We also had in our previous institute when I was working for Kamini, in that place we had some strips for the plant allergens like Parthenium, Chrysanthemum, Xanthium. Ready-made. I believe it was to test only. Strip.
No, it was not. It was part of these people only. It was there for a short time. Then it went.
Yeah.
Agar,
Apart from the ready-made the syringes what we are having in the ISS, there was this strips which with some four different types of plants.
yes, I know. For some time it was there. I think they were experts on or leaves directly. Something like that. The one suggestion I give for hair dyes, especially if you want a good color and you don't want anything artificial, they can use pure henna with coffee and tea grinds. Give a nice brown color. So that's another advice. They can use the coffee with the henna. It has to be henna leaves again because all these henna powders they'll contain what we don't know. So people react to those also. You can advise that.
Henna with indigo dye also, ma'am. Indigo from the naturally obtained indigo, a proportion of this gives a good black color. Many people tolerate that. Henna leaves with indigo leaves. I'm not sure of what those, the plant name, but a natural indigo.
Indigo was a very highly grown in India, no, for this denim. Indigo dyes are back in fashion also. They use it for denim. And, yes, that's a good idea. Is it available easily?
Pondicherry, Auroville has it, ma'am. So,
Must be using for this.
so many people use that.
So, anything else? Um, so let me conclude then.
Madam, you can see if there are any audience questions.
Sudha?
No audience questions, madam. Only no audience questions. Send one message. I don't know, maybe it is in like an answer. People cutting pineapple, coconut, mango, star juice, garland makers due to flowers. That is what they have posted. Maybe these people also get allergies. What kind of allergies or what?
The mango we already spoke about. Composited, we have seen in flower sellers many times, very severe hand dermatitis. And sometimes that can become converted to airborne, especially this chamanthal, all this seasonal, they have this allergy.
And garland makers due to flowers.
That's what I'm saying. So
that also same hands.
Even housewives who plug the flowers with white liquid sap daily, so they develop allergy on the fingertips.
Yes. So another reason for fingertip dermatitis. And we didn't cover foods, of course. See, this is an ocean. Where Suzanne is saying patch test verbally, you will not know anything. Yes, you can't know anything because it's a huge. It's never ending, I feel. But you have to start somewhere, and every little bit counts. I think we have to grasp at whatever we can while swimming and go ahead.
One last question, madam. Anyone had any experience or anyone has seen these systemic contact dermatitis cases diagnosed and treated?
Actually, probably we miss it.
I've seen it, but
Yeah, with the cross reactions to dyes, like urticarial reactions, we've seen some. But actually, recent time they presented about some drugs, actually NSA, pyroxicam, very severe for nursing staff and who they prepare for injections. In the recent Corficon they were presenting how little amount of intake also it makes their life. But I'm sure we are missing some cases. I think we should.
Sure, 100%.
We see a lot of these systemic contact dermatitis for native medications, ma'am. They
Oh.
Siddha and all that they apply topically, and the same thing they take in intake. So that they are all present with systemic contact dermatitis. Invariably, all these patients who come with history of native or Siddha applications have systemic contact dermatitis.
But I think latex and marking that are some examples of that. Latex also is supposed to cause very severe reaction. But you have to be aware if they had hand dermatitis and they feel it's mostly swollen and urticarial, and you should advise them non-latex gloves.
Now, if you permit, I have one thing to clarify. Actually, when we were discussing about the wet compresses for topical application, I was talking about wet wrap therapy. For atopic dermatitis children, we were using no, ma'am.
Yes.
That we dilute the steroid with liquid paraffin, we apply and then dip the cloth in running tap water, cover the patient, and then cover with the shirt, like dry shirt. So that usually helps most of the patients because it gives a soothing effect and this inflammation gets controlled quickly and we need not hike up the dose of steroids. For oozing lesions, we give wet compresses with normal saline.
Mm-hmm.
But in a whole lot of these erythroderma, especially airborne contact dermatitis, if they are highly diabetic and we are not able to control their sugars and all that, it's a good alternative. We try that for a lot of erythroderma cases, just for short period. So that
what is it, ma'am? Liquid paraffin with steroid, or you said tap water?
Liquid paraffin with beclomethasone, ma'am. We dilute it as 1:4 dilution, apply all over the body, and then we ask the patient to wear a shirt dipped in tap water over it, and then on top of that, a dry cloth. Like the same thing what we do for children with atopic dermatitis.
Yeah.
Wet wrap therapy.
Wet wrap therapy. The same thing we try for adults with erythroderma.
So are you doing for children? What about absorption then? It must be quite a bit must be getting absorbed. There's a fairly potent steroid,
Yes,
no?
ma'am. Yes, ma'am. Definitely the systemic absorption. We don't give them systemic steroids. We try to manage with the topical steroids. For example, some patients we have doubt of whether they have tuberculosis and all those things, where we don't want to give something systemically and we want an acute control.
What about cyclosporine? You don't use it?
Cyclosporin we give for those cases where we suspect adult onset atopic dermatitis, ma'am, not for the routine or the chronic actinic dermatitis. Those kind of patients. Chronic actinic dermatitis, ma'am.
Azathioprine definitely does. Methotrexate does. I don't know about cyclosporin.
Cyclosporin works very well in actinic contact dermatitis, ma'am.
Okay.
Chronic actinic dermatitis, especially when they're present with the
Azathioprine also. Our preference here is azathioprine rather than cyclosporin.
Mine also is azathioprine, but less cyclosporin is less immunosuppressive in that sense. No, that's why.
And quick control will also.
Fast acting.
Basically, azathioprine is more safe, but cyclosporin is more quick acting and it acts a faster action.
We use it in refractory cases mostly.
Dr. Malti madam, regarding immunosuppressives use just before the patch test, like in case of corticosteroids, of course, like 10 to 15 milligrams of will be still okay just before the patch test is performed. What about azathioprine, cyclosporin, and other immunosuppressives? Do you stop that much before, or are you
have to stop it, sir, at least for a month and only then give?
Because I came across recent literature where they have mentioned little different about it. They are saying like there is not much effect of these low dose azathioprine or low dose cyclosporin on patch test results. That is the literature recently.
But also they have said, but I've shown you 2 cases. No, even after stopping low dose, the reactions weren't as strong as one would expect, or they were positive. So there are 2 views on that. In the beginning only, they said that the immunosuppressants will suppress the patch test. Some people say you can give it and you can do it.
Similar to what we can do with corticosteroids, like 10 to 15 milligrams, we can still continue. That low dose azathioprine and cyclosporin may be still okay to continue. That's the opinion now.
We generally, when we taper the patient to 15 milligram, that time we patch test and only then we start on azathioprine. We follow that as a routine policy, sir. Okay. We make it a policy so that before we know that the patient is going to have long-term immunosuppressant, we always make it a point, we patch test it and then start on azathioprine.
But that we can't do in all conditions. When there's very extensive, there's no place.
It's difficult, ma'am.
Okay, then. So, shall we conclude? So, contact us. Yes, we had a good discussion. Thank you, everyone, for your great inputs. So, we have gone through that various the pathological processes, various ways of presenting, and so you need to have interest in it, have patience, perseverance, and a method to be beneficial to the knowledge. So, you have to patch test, you have to learn what to prescribe while waiting to do or unable to do patch test. This is what I wanted to stress more and more. Please look at what you're prescribing, even if there is a small suspicion of patch allergens, because you can get it quickly under control and then go and do your patch if you are able to. And updating we spoke about. So be aware, prescribe with care, patch test as much as possible, and please record and discuss the information. Dr. Naeem, this is especially for you.
Thank you.
And please, all of you have the facilities, start doing a little more in this. Thank you. Thank you so much. Thank you very much, Dr. Malti, for coming on.
Thank you all.
Thank you, ma'am. Thank you, madam, for the wonderful moderation and very good informative session. So this is our last webinar in this year, and I thank all the speakers and panelists and moderator, Dr. Pavitravani Patala, madam, Dr. Malati, Dr. Jyotsna, Dr. Neetu, Dr. Kavita, and Dr. Naeem Sadat and Dr. Anand for making this event more successful. And I thank TSIADVL and Pavitravani Patala madam for giving me this opportunity. I wish you all a very happy and COVID-free New Year. Thank you.
I would like to thank this topic for supporting this. And also, this is our last 2020 TSIADVL webinar as well, not only the year 2020.
Year, true, madam.
We disperse after this.
Yeah.
Thank you.